Everyone let it in the room?
Hey, Raj, we can hear you.
Hey, Sachin, can you turn my mic down or my microphone or earpiece down?
Raj, you're looking good.
Okay. Hey, Sachin, good morning.
Morning.
Can you turn mine up a little bit?
Raj, we also have Josh Obak, who was a trainee of this institution, joining us. So, really proud of all the things that he's done. And he's going to be the co moderator for this live case. Welcome, Josh.
Okay, thank you.
Fantastic.
Yeah.
Well,
And
you guys are going to keep me on time then, huh?
yeah, absolutely. And also a huge shout out to our directors, Lula, Amy, Chanel. They've done a fantastic job organizing this course, and I see a lot of familiar faces in the audience. So thank you for being a part of this. We really appreciate it. So, Raj, what do you have?
So, Sachin, we have, there was a case presentation. Um, I don't know if we could pull that case presentation up. Does Kirk have it?
We're looking.
Okay.
While we do that, Raj, do you want to just give us one or two sentences on what this case is about?
Yeah, it's so that you don't see the real
It's
patient
blinded.
information.
It's not the real.
No, it's
Uh,
that's what they told us.
so this is a patient who had presented with abdominal pain and has a bile duct stone. And on imaging and abnormal LFTs. So we're planning, they've not had prior access before. And so we're planning to do an ERCP and hopefully biliary access and sphincterotomy for stone extraction. I think on the case presentation, there's some imaging that shows, did we break the channel?
But that's
No.
great.
Okay.
Do you want
So
it?
yeah, with the
Post-
wire.
Yeah.
So I wanted to point out something that we're gonna. I don't know if you can see Amy's hands. Go ahead and say
I
something,
can.
Amy, and the camera will track you.
Hey,
Hi,
There
Amy.
you go. So I don't know if you can see Amy. Can we lower the camera down to see the channel of the?
Raj, before you do that,
Yeah.
we actually have the case presentation here, and
Oh, perfect.
Josh is just going to go over the case presentation, and then we'll go live. Right now, we just have the case presentation up.
So looks like this is a 70-year-old male who has a history of prior cerebral vascular accident and presented in March with right upper quadrant abdominal pain. When they came in, they had an MRI with an MRCP showing irregular and focal gallbladder wall thickening in the gallbladder body. And so this
Bring this
concerning for
camera
possible cancer in
so we
that
can see.
region, as well
You
as
want to
some
lower the?
stone
Can you
burden
lower
with
the boom?
dilated common bile duct measuring
Just
about
lower.
13 millimeters in diameter. Patient had labs performed showing no evidence of anemia or coagulopathy on INR or platelets with normal transaminases and bilirubin level, as well as I don't see an alk phos there, but I think the alk phos was normal as well. CA19-9 cancer marker was within normal limits, as well as alpha fetoprotein
Go a little
and
deeper.
CEA level. And the patient was referred for ERCP
Keep
for
going.
extraction
Keep going.
with planned diagnostic laparoscopy followed by open cholecystectomy
Keep going.
for resection of any bile duct
Yeah.
or
Okay.
lymph nodes, given the concern for malignancy. So, Raj, you said there was concern for stone on MRI, or there was a noted stone on MRI, or just a dilated bile duct?
Can we go to the next slide?
I reviewed. Oh
There
yeah.
you go.
Oh, never mind. That looks pretty stony.
Yeah, yeah.
Did it? Okay. It's been a bit since I reviewed that imaging, but I recall it being an obvious stone.
Yep.
Yeah,
I don't see the case present.
there's
Oh
an,
yeah, I see it there.
there's
Yeah.
an obvious stone there. I can
Yeah, there's an
Yeah,
obvious stone.
nice.
Measures about
That's
10
a nice example, huh? Yeah.
millimeters. Do we have any other slides, or can we go live? Oh, there's a video of the MRCP. Can we run that, please, Kirk?
That's okay.
That's okay. All right, let's go live. Raj, you're live.
Yeah. Okay. So now you see, I have Amy Marquisio here, RN extraordinaire, that's assisting me today. Christy Tronics in the back trying to hide from camera, but she. Oh, you see her hands there.
Yeah.
And some other
Christy.
folks helping out. And then Alex from Proximy is helping us with the streaming. Kirk's in the background there. And so this is the for some of the, I wonder if you could get a show of hands, Such and Josh, about number of attendees that participate in ERCP during their workday.
So it looks like we have probably about half the room raising their hands.
Half the room. Okay.
That's
So
great.
for those that don't, this is the major papilla in the second portion of the duodenum. And I'm just reorienting the fluoro here. Now, just so I know, are you able to see the fluoro view, the endoscopy view, and then the camera views between Amy and myself?
You got it.
Okay. So you can tell, I don't know if you can appreciate, are you able to point out how straight the scope is, Sachin, with the pointer,
Yep.
with that laser pointer?
Yep. I got it.
And so it's a very straight scope position. And what we have, this is actually a short wire system. And I'm going to ask Amy to actually bow up the sphincterotome. And I think you'll be able to see, and it's really small increments of bowing when this is done. And if you're not too happy with the orientation, you can always rotate this one. This is the autotome, sphincterotome, but it is rotatable. So in fact, what I might do is have Amy bow up about halfway.
Okay, going half.
Okay. And now I'm going to have her rotate counterclockwise about 3 times. And so what that can do,
One,
oh wait, maybe 1 is enough. Go ahead and relax there.
relax.
Yeah, okay, that kind of changed the orientation. And I don't know if, Sachin, if you could point out like the papilla and sort of that intramural portion of the bile duct, and then we're trying to go parallel to that on the endoscopic view. And where the bile flows doesn't always mean that's exactly where the opening is. I know that I get fooled on that too sometimes, but you try to go to the apex of it, of the papilla. Now, this papilla is a little bit maybe on the medium size to small, so I'm going to ask Amy to advance the tip of the wire a bit.
Okay.
And all of her movements are fairly
Advancing.
slow, and she's experienced, so I'm just kind of more out of illustration explaining kind of what we're doing. And then, Amy, please chime in if you feel
Okay.
you want anything more to say about it or any other tips regarding that. Are you bowed still, or are you?
I'm relaxed.
You're relaxed. Okay.
And Raj,
I
this
always
is
just make
actually one
sure
of the
it's
first steps that we take, even when we start our cases, is to take a nice view and image of the papilla, because once you get into difficult cannulation cases, really understanding the trajectory of the bile duct is critical, especially for advanced cannulation techniques.
Amy, yes, thank you, Sachin. Amy?
I was just gonna say I'm always making sure that the tool is flush with contrast before, because I wouldn't want to accidentally push air up into the duct. And then I want to keep a good distance so I'm not like looping the tool. It makes it a little bit easier for the doctor.
Can you hear Amy okay?
Yeah, loud and clear.
Oh, fantastic.
Yeah,
Okay.
that was great.
So then I'm going to, so on the fluoroscopy, this the sphincterotome is angled a little bit midline. And so I'm going to zoom up one. And you can see that the sphincterotome is aimed up a little bit more toward the PD, which I don't like too much. So I'm going to ask to bow up a bit here.
Okay. So I'm just closing the device a little bit, which makes it bow up.
And Raj,
And you can see Amy's hands.
Yes.
just for our audience
Okay.
members here, so Dr. Shah is trying to follow that intraductal
Bow up a little more.
bile duct
Bowing
segment.
up more.
The bulge into the duodenum, and that's really the trajectory that he's trying to look for endoscopically. He's also
Okay,
using a
try the
combination
wire
of
here.
fluoroscopy
Oh, wait, that's
where
actually
his
tell them
device is going. Is
what
it
you're
going
doing.
towards the right upper quadrant where the liver should be in the bile ducts, or is it oriented more in a medial position towards the spine, which would be concerning for pancreatic anatomy? So he's using a combination of endoscopic as well as fluoroscopic guidance to try to figure out where to go.
So go ahead, Amy, go ahead and if you can explain what you're doing with the wire, see what.
So I can take my hand off the bow, it'll stay where it is, and I'm gonna try the wire. And I'm gonna do really gentle, like pokes, so that I don't, if I push too hard, I'll knock him out of the papilla. And then I'll be able to feel when I'm in the duct, and I still feel like I'm hitting up against something. And it's just really gentle.
Why don't we try this? Why don't we bow up a little bit more?
Okay, bowing up more.
Okay. I'm changing my position slightly to see if that angle can be enhanced. You're trying to get above that septum between the PD and the CBD. Right now, I really don't know if I'm in the CBD or PD or just in the common channel. It does feel like the tome is buried a little bit. So go ahead and try the wire now.
Okay, I'm going to try the wire again. I still feel like I'm hitting something.
Oh, wait.
Oh, actually,
I
yeah.
think
Did it
we're in.
give?
Yeah, nice job, Amy.
Okay, now here, what I would give one suggestion is that it looks like it's heading toward this CBD, but sometimes the PD can be running very parallel to the bile duct. So I usually will ask the nurse or the assistant, the tech, um, to pause with the wire. Once it gives, I ask for, I'll do fluoroscopy. We run our own fluoroscopy. Go ahead and advance there.
Okay, advancing.
And that looks like it's heading to a bile duct. So I think we're okay to keep advancing a little bit off fluoroscopy. Stop there.
Stop.
I usually try to just minimize our fluoroscopy whenever possible. And then if you know, go ahead and break the wire. So if we can show that, we can see the hands.
I want to make sure the wire doesn't move.
Can you raise your hands just a little bit? Yeah. Can we move the camera a little bit toward the working channel slightly? Just so we can see the, yeah, there we go. That's good right there. Okay.
Going back. There. All right, so I'm making sure that I'm going to strip the wire with my right hand, but I want to hold it with my left hand so it doesn't go in. And I'm just going to, there's a little break in the tool, so I'm going to slide my hand all the way down so that he has control of the wire. And I still want to have a hand on the wire until he locks it, which he just locked it. So now I can release the wire to him.
And then she's releasing the wire because it's a short wire, and then it won't drag on the floor usually. I'd say, what do you think, majority of the time?
Unless the doctor's really short.
Yeah. Oh, I see. Okay. Yeah. Okay. But otherwise, if it's long wire, of course, it'd be a different technique as far as being able to drop it. So I'm just gonna, the wire is right now, probably I would estimate around the common hepatic duct. I'm just gonna move the fluoro to minimize this a little bit. Is that gonna hit the monitor, or are we good there?
So what Dr.
I think we're
Jagan
good
and
there.
Amy just
Okay.
showed you was how we typically cannulate
Go ahead and
the
inject.
bile duct, which is a wire-guided or a wire-assisted approach to cannulation. There's been a lot of literature describing that this technique is far better than just injecting contrast into the bile duct. It reduces the risk of post-ERCP pancreatitis.
Injecting.
So on the cholangiogram, that's good right there. You don't really have to over-inject. We know we're going to do a sphincterotomy, and you can see multiple filling defects. Maybe you could point that out with the laser. Laser thingy. What do you call it? The laser pointer. There you go. So on the cholangiogram, you can see in the lower third there are multiple filling defects. We're going to prepare for sphincterotomy. And the other thing we can do with this technology is I'm going to measure the bile duct. I would estimate that the bile duct is probably about 12 millimeters, but now we can actually see if I can measure that for you. And it helps decide what size balloon to use. And sometimes we'll know this in advance just by the MRCP or CT scan. And let's see what we got find here. That's about 10. About 10, maybe a little bit more dilated distally. I think a 9 to 12 balloon would work. So, what I tend to do is I try to anticipate devices to allow, the other question of the 50% or so that do ERCP, how many of them have a tech or nurse? Like, are there 2 people working to support that case or just 1? And do you have any suggestions, Amy, as far as how to utilize your partner if you do have a partner that you're working with?
Yeah, I mean, the partner is always listening, so you always have to have your ears turned on, and just preparing tools, thinking ahead that what the doctor may ask, and you really get to know your doctors well and what they may like. If we're cutting right now, Christine, are you ready to hook up?
Yeah.
So I'm hooking them up to heat, and our patient is grounded to the cautery device.
Blow up a
So I
little
just
bit.
want to make sure the patient's hooked up. I'm going to bow up. And I don't like to hook them up until they're actually ready to cut, because they could accidentally step on the pedal and make cuts where they don't want to.
The cautery setting I'm using, this is the Irby Vio. Actually, I don't know. It's a newer one. Sorry, I don't know the model, but uh, is it the Vio 3? Okay, so this is a 243 setting that I'm using, and that's another question to ask the doc, the endoscopist, about what setting they want, which I think would be pretty standard once you establish what you prefer.
So Raj, can you tell us
So
a
I'm
little
using,
bit about the direction in which you're going?
yeah, so I'm trying to use the intramural portion of the bile duct, the intraduodenal portion of the bile duct, to gauge not only the trajectory, but also how far you can go relatively safely with the sphincterotomy. And the stones are a reasonable size. I think the largest is maybe 8 millimeters. So I want to try to do maybe a 10 millimeter sphincterotomy. And so to be sure that we can extract them all with an extraction balloon. Sometimes there are some advanced techniques that are required, such as basket or interductal lithotripsy with cholangioscopy. And we'll have a case of that probably tomorrow. So hopefully you all are staying for the additional live cases tomorrow.
I think Dr. Shah, you did a great job staying oriented between that 11 and 1 o'clock position there as you're doing your sphincterotomy.
Relax all the way
Making sure to
Relaxing.
avoid any type of
and
perforated vessels
disconnect.
that may lead to a post-sphincterotomy bleed, which can be pretty dramatic if you nick something like that. That can really cause a wrench in your procedure.
So Raj, can we talk a little bit about that? You and Amy, what are the complications that you can encounter up to the steps that you've done, and how would you tackle them, and how are you prepared for those complications? Bleeding, right?
Yeah, you know, sometimes some bleeding is part of the sphincterotomy that'll be self-limited. So there's a little bit of bleeding now, but I'm not concerned about it till toward the end of the procedure. And if it stops spontaneously, then nothing further. We do a scalp film on fluoroscopy to look for air patterns. And then if we're worried about extension of the sphincterotomy or other for perforation, then we look at for air. And then those are the two main things, you know, if you want to avoid pancreatic duct cannulation as well. I don't want to overlook the fact that Amy had placed the wire or the extraction balloon over the wires as a short wire system. And normally there is, do you mind commenting on what that tail usually is?
Yeah, there's a little tail that comes into this device, and it helps guide the wire out when you're putting the tool over the wire. So it just helps it guide through this little hole right there. Yeah. And then I'm just supporting the tool and holding the wire until he locks it. He just locked it. And then we use our armpits a lot to hold devices. So that's why Christy put the tool in my armpit. It's our third hand. And then I'm going to hook back up to contrast. She already flushed the device for me, but I always just verify and make sure she did. So I'm not, again, flushing air into the duct. Could look like that, stones or.
Exactly. That's an important point, is flushing prior when you have the extraction balloon up from a standpoint of air bubbles, as Amy mentioned. So generally, so if we can, if you want to go through, I think I'm going to do a 9 millimeter first on how to get a 9 millimeter with the 9 to 12 balloon.
So there's a mark for 9 and there's a mark for 12. When I go to 9, I'm going to want to go all the way up to 12, inflate the balloon, and then come down a little bit to the 9.
And sometimes do you sometimes, and then sometimes do you come down not all the way to 9?
Yeah, I'm right above the 9. If I come down exactly to the 9, a lot of the times it won't inflate, and he'll pull the balloon out, and you'll realize it was never inflated. That does happen.
Balloon down.
Right, balloon down. When he's out of the duct like that, I know I can take the balloon down, and I just unlock this little piece here, and it deflates the balloon.
Let's go to 9 again.
Okay.
I think
So up to 12, down.
A good job here. You're going from downstream to upstream as you're doing your stone extraction, which is, I think, an important point to highlight here, that you're not going all the way to the top of the common hepatic duct to extract these balloons so that you don't log jam them or bottleneck them at the ampulla. So going from a downstream to upstream orientation with the balloon sweep here to remove the stones when they're stacked like that is a great point to highlight.
Go to 9 here.
Okay. Going to
That's a
9.
nice stone, Raj.
And we,
I don't know if your endoscopists get excited when stones come out. We get pretty excited when we take stones out
We
of the
do.
duct. Yeah. Right, Raj?
And I'm always repeating what Dr. Shah says to me so he knows I actually did what he wanted.
thanks for bringing that up. Yeah, I agree. We get very excited about stones,
do.
especially stones. Pigmented stones are less common than cholesterol stones for bile duct. The closed loop communication is really important, and I'm glad you brought that up, Amy. So I'm going to say, let's try halfway.
All right, so I'm going up to 12, and then I'm going halfway between the 9 and the 12, and then I lock.
And sometimes I'll reduce the balloon across the sphincterotomy just to reduce inducing any bleeding. It's not like it's significant bleeding. I just don't like dealing with it. So go ahead and go down a little bit.
Okay, I'm going to unlock, but keep my finger on the device.
There we go,
and
good.
Come down to 9,
Balloon down.
and then I can go balloon down.
I think those are still the same ones. I think we're going to go up to the bifurcation, and we're going to go to, let's go to 12 here.
Okay, 12.
Any questions from the audience? Okay, now come down a little bit.
Coming down. That was to 9.
Oh, that was good. Okay, balloon down.
Down.
So you remember like my cholangiogram with the initial procedure right here, and it wasn't a complete cholangiogram, but that's okay. You know, we decided we're going to do sphincterotomy anyway. So now we're going to get a better cholangiogram, be sure there are no stones hiding up at the bifurcation. And you noticed Amy's movement. So as I'm advancing and it starts getting a little bit of tension, she kind of takes a step in or moves forward. And then as she mentioned earlier about keeping that straight, you know, to allow for devices and so forth. So that's very helpful from an endoscopist perspective too. Go ahead and go to 12.
12.
And then inject a little bit.
Okay. And this is a rapid refill that I'm using, injecting. And I continue to tell him that I'm injecting.
Stop injecting here. The one thing we should bring up too is, did you dilute the contrast? What was the ratio? Was it about 10% dilute or 20%, 30? We diluted a little bit. Sometimes it gets a little sticky. This is adequate. Is it the?
Depends what concentration you have.
Yeah, it does depend on that. Yeah.
The 300 ISOView.
300. Well, what's the percentage? Is there a percentage on it?
30%.
30% ISOView? Okay.
This is a little less.
That's the less
diluted.
Okay. Yeah. So go ahead and inject here.
Okay, I can actually refill my syringe by just pulling back, and then I'm going to say injecting. Injecting.
So
A little bit of sludge coming out.
Is an occlusion cholangiogram to really
Injecting.
confirm
Stop
that
there.
there are no more stones left in the bile duct, no strictures. And of
Come
course,
down a little bit.
Patients who've
Coming
had a
down.
cholecystitis.
For about 5 minutes.
Simply, you want to also ensure that they have no
Come
contrast
down a little more.
visualization. So
Coming
these are the things
down.
that we
To 9 maybe.
9.
Oh, we had another stone.
Another stone.
There was another stone. All right.
And,
So about 3 maybe and a little bit of sludge. Balloon down.
Down.
So I actually thought that the filling defects in the duct were just air bubbles, and I think they are, but there was a stone just, I usually would do a couple sweeps just to be sure I'm clear. Go ahead and go to 12. But I'm not compelled to necessarily repeat a cholangiogram and use more fluoroscopy and all that stuff if I come down just a little bit here. If I'm pretty
Down.
confident the stones are cleared with sweeps. Balloon down.
Down.
Sometimes the air bubbles are a little confusing too. So I'm pretty comfortable with this. I'm going to do one or two more sweeps. Go ahead and go to 12.
12.
And now the bleeding has actually subsided, it looks like. We're going to watch it a little bit for a minute or two, probably a little longer than the nurses really like. Go to 9 here.
Down to 9.
There we go, balloon down. So we've had 2 sweeps that were negative. I put a 12 millimeter balloon initially, and there's no active bleeding there. So I think I'm comfortable with it. And I think we're done. We'll probably watch just for about a minute here Do you guys have any questions or anything else you want to do before we go to lecture? We're going to turn over the room and then plan to do the endoscopic or our next procedure.
Hey, Raj, we have a couple of minutes. Just wanted to go over a few things. So can you just talk to all of us in terms of the
Go
conversation
to
that
12
you
again.
and Amy and Christy had
Well,
before this case in terms of preparation? What did you tell them? What
Come down to 9.
devices? How did you prepare for this case? I think this is an important aspect of what we
9,
do, which is to communicate with the
Balloon down.
nurse, anticipate the devices that you'll need and the procedural aspects. And the second question, Raj, is what did you do to minimize the risk of post-E or CP pancreatitis for this patient?
Yeah. So what's his age? He's
70.
70.
70.
So 70-year-old male with bile duct stones, the lowest risk for posterior CV pancreatitis. So at least in my practice, and it'll be interesting to hear Josh Sachin regarding your opinions related to this. But I do about 2 liters of normal saline during the procedure. And then I actually hold off on indomethacin unless it's a difficult cannulation or if the patient is high risk. And this is partly related to our SVI study, which Sachin can talk about to you. But I'm off camera, or when I'm off camera. But in eligibility for that study was difficult cannulation was defined by more than 6-minute cannulation. And so I don't think that this patient fits into that category for SVI, which is this prospective study that was done comparing indomethacin alone to indomethacin and PD stenting. So what I did is 2 liters of fluid, no indomethacin. What's the cost of indomethacin these days? I think it's a couple $1,000s now. When we first started using it, it was literally $50.
Yeah.
Now it's more than $2,000, but that's not the reason alone. But I just think the evidence for this simple cannulation and stone case in low risk patient is not there. As far as the communication with the Amy and Christine in advance, we talked about the type of case, or they reminded me of the type of case. So they review all of our patients in advance and are as familiar with the patients as I am, sometimes more so, as far as the procedure. And then we go over the devices that we're going to use, whether to open the devices in advance or not. I'm going to turn off fluoroscopy, which is important to have that. We're going to just send it. Can we switch to fluoro? And then we talk about plus or minus indomethacin, IV fluids, and I think that important communication in advance of the procedure, in advance of the patient, even in the room, I think is very helpful.
Fantastic. Fantastic job, team. Raj, Amy, Christy. We'll see you in a little bit. Thank you.
All right, thank you guys.
Bye.
All right, bye. Didn't my picture of the stones come up?
All right, that was pretty cool. Stone cases are typically our favorite. They're very satisfying. Those were some beautiful stones that we got to see. Next, we're going to have a lecture by Dr. Joshua Obuck. He actually did his general GI and advanced interventional fellowships here about 7 years ago. So it's great to have him back. And please give him a warm welcome.
Thanks for Hi, good morning. Thank you for that wonderful introduction. So my name is Josh Obuck. I am one of the advanced therapeutic endoscopists for the Geisinger Healthcare System in Pennsylvania. And I'm also the medical director of endoscopy at my institution at Geisinger, Wyoming Valley Medical Center in Wilkes-Barre, Pennsylvania, and northeastern Pennsylvania. And today I'll be talking to you about endoscopic ultrasound. Let's see here. I unfortunately have no financial disclosures. So when I was thinking about a nursing course and what I would think the nurses would want to hear about from an endoscopic ultrasound standpoint, I kind of polled my nurses in my endoscopy suite and got their opinions as well. So what I was hoping to achieve today with our 40 minutes is to kind of just understand the basics of endoscopic ultrasound imaging, what the technology is and how we actually generate an image when we're doing this. Appreciate the differences in the ultrasound scopes and probes that we use in the endoscopy suite. Also to become familiar with common diagnostic and therapeutic endoscopic ultrasound procedures, specifically the needle-based procedures, as well as some of the advanced therapeutic techniques that we've been starting to do with the invention of lumen-opposing metal stents. Sorry, you guys are using the thing here. Okay. So when we talk about endoscopic ultrasound, the frequency of sound is usually, for what the human ear can detect, somewhere between 20 and 20,000 hertz. And beyond 20,000 hertz, that's sound that we can't hear. That's why you hear like a dog whistle, they're freaking out, and we're doing okay because we really can't perceive it. So ultrasound frequency is a spectrum greater than 20,000 hertz. And for medical applications, the use of frequencies in the 1 million to 50 million range, or 1 million to 50 million megahertz, thank you so much, is really what's used for medical applications. And ultrasound is essentially mechanical energy in the form of vibrations from sound waves that propagate through a medium, such as air, fluid, tissue, etc. And when we think about how sound travels through a medium, it's a relative index of the density as well as the stiffness and compressibility of a substance. So if you think of something like water, air can travel through something like water that's relatively compressible and not super stiff, versus something like bone or vertebrae, where that you can't really compress and it's extremely stiff. So air travels faster, the acoustic velocity, through a solid or stiff medium than it would through a compressible or less dense medium. That's why if you are talking right now, air travels, my voice sounds the way it does. If I were to be underwater and yell, it can sound louder when you're underwater, and the sound waves can travel faster through that medium. And it has to do with the relation of the characteristics of the medium that the sound wave is traveling through. So the transducers on an ultrasound probe, they have polar crystals, and they're aligned to change shape when the electric field is applied. This change of shape causes mechanical vibrations of these crystals that generate a sound wave, and that reflected sound wave then travels through a medium, hits an item of interest, such as a tumor or the liver or the pancreas, and that sound wave then bounces back, and it hits these transducers, deforms the transducers, the crystals in the transducer, and that creates another energy form in the form of electric energy that then goes to our processor, and that relative energy that's created from this distortion of the crystals causes an energy impulse that allows for an image generation on the processor. So it's essentially sound that's getting interpreted into electrical energy, and the processor can then be used to make an image out of that. So the take-home point for that is that transducers generate and receive acoustic signals via polarized crystals in the ceramic tip of a probe, and these crystals then deform based on sound wave reception, and the processor can control how loud the sound wave is, what hertz we're using, and can control things like gain and image intensity. And the take-home point is that the tip of the endoscopic probe has little crystals in it. Don't bang it around. Don't knock it around. They're very, very, very sensitive, and if you damage the tip of an ultrasound probe, it can really cause issues with acoustic interference and poor image generation. So the tip of the probe is very, very sensitive and needs to be handled delicately. So now that you guys are all experts on how sound waves generate images, what are we using this amazing technology for? So indications for endoscopic ultrasound, we tend to break it down in terms of diagnostic imaging as well as therapeutic implications. So from diagnostic imaging standpoint, we can do things such as tumor staging, assessing masses in the pancreas or within the luminal GI system. We can evaluate pancreatic cyst accumulations or areas that have accumulated fluid outside the luminal GI tract. Evaluate pancreatic anatomy for chronic pancreatitis evaluation, or even as something like a biliary lithiasis evaluation. You saw in that last case, the patient had an MRI. Patients who can't receive an MRI, if we have equivocal risk for them having stones in their main bile duct, an endoscopic ultrasound is a great tool to not put a patient through the risk of an ERCP to determine whether or not you need to do that type of procedure. In terms of therapeutic implications, we are able to do extraluminal collection drainage, and we're also in the realm of now creating intentional fistulas through the luminal GI system in order to intervene in a minimally invasive or a non-surgical setting in terms of natural orifice endoscopic procedures. We can also do pain procedures for palliation as well as biliary and pancreatic drainage procedures. So when we look at the probes, there's essentially two different probes, well, three, but the main two that are in most endoscopy suites are the radial probe, which is strictly diagnostic, and then there's the linear probe, which can be diagnostic as well as therapeutic. The linear probe does not have an operating channel for devices to pass through. It simply is generating an image using the ultrasound technology, but sampling of things using needles and things like that cannot be performed using a radial ultrasound probe. The linear ultrasound probe, as you can use it for diagnostic purposes, but can also be used for therapeutic intent or diagnostic intent with biopsies and or fistula creations with other specialized devices. And then a takeoff on the linear probe is the forward viewing endoscope. So it has a similar type of transducer to the linear probe. However, it's been smushed essentially to the front of the scope. And that has to do with the optics of the scope. So a linear forward viewing EUS probe allows the endoscopist to visualize endoscopically where they're going. The visual field on a radial and a linear probe is at an oblique orientation, and the endoscopic images with this are not that great. So here's another take here just to highlight. We have the radial probe here, the transducer, and this is the linear probe here, the transducer, and the plane of image generation is different for the two different types of scopes. So you can appreciate with the radial scope, the image generation from the sound waves is perpendicular to the probe, and it creates an image that almost looks similar to a CT scan on axial imaging. So we use the ultrasound and we get kind of a cross-sectional image based on where the probe is located relative to the organs and areas of interest. With a linear probe or a linear transducer, this is oblique and kind of does a oblique angle in terms of the image generation for the sound wave propagation. And it really requires device manipulation and orientation to get a better understanding of the anatomy that you're visualizing. So a little different in terms of the visual field that's generated. Here's a different schematic here. You can see a radial ultrasound probe in the lumen of the esophagus with cross-sectional interface, and what you get generated is an image that almost looks like a CT scan on axial imaging, versus a linear probe with the ultrasound probe oriented in the duodenal sweep here. We're looking up at the pancreas, and its orientation is oblique to the scope tip. And then here there's the optic lens for the ultrasound probe at an oblique angle. So where the tip of the scope is not necessarily what you're looking at. So what the endoscopist is seeing endoscopically is not the end of the scope. It's seeing just kind of at an oblique view towards the tip. And it's something to be cognizant of when we're doing these procedures so that we don't inadvertently cause a perforation or injury to the lumen with the stiff transducers. Just a quick blip on the processors. Each echo endoscope requires a distinct and unique ultrasound processor. So there's multiple manufacturers that have different scopes for endoscopic ultrasound. These scopes are not interchangeable with the processor. So one manufacturer's processor goes with that manufacturer's scope. And with the processor, we're able to control from the endoscopist standpoint, do we want to just have it on acoustic imaging mode, such as B mode, where we're getting anatomic evaluation of the areas of interest. We could put on Doppler flow to look for areas that are concerning for possible vascular structures. We can change the gain of the intensity of the images that are generated and zoom and focus. So very complex machinery that allows us to manipulate these scopes, the image generated, and to help us with our diagnostic and therapeutic interventions. So just starting off on some basic techniques here, one of the main things that we do using endoscopic ultrasound is tumor staging. And for luminal tumor staging, in my practice, I tend to use a radial probe. However, we can use linear probes for things like staging for pancreatic cancers or extraluminal cancers. But for luminal cancers, tumor staging with the radial probe is a great way to do this, especially if you've already had a diagnosis and don't need to necessarily sample things outside the extraluminal GI system like a lymph node or a possible concern for metastatic disease. But here's a video. Please work. Okay. All right. So here we're doing on endoscopy, you can see there is a GE junction tumor, gastroesophageal junction tumor that was previously biopsied showing adenocarcinoma, and the thoracic surgeons requested that we stage this to see depth of penetration. And so here in the center of the screen, you can see tumor that is located on the screen here to go through depth of penetration beyond the epithelial surface. So most cancers originate from the epithelial layer, and then as they start to invade through the basement membrane, they can then penetrate to the underlying tissues of the organs, such as the submucosa, muscularis propria, the serosal surroundings, and into adjacent structures. So using the ultrasound probe, we can endoscopically stage how deep of penetration this tumor is going through to help with staging for the patient so that they can appropriately undergo the requisite therapy. So if we do need to sample something such as a pancreatic tumor or something outside the luminal GI system, that's where needle biopsy comes into play. Most of us in the endoscopy suite are fine needle aspiration and fine needle biopsies are our workhorse. We use these almost daily for endoscopic ultrasound. And the differences in the two technology essentially have to do with the tip of the needle. So there is fine needle aspiration needles that are essentially harpoon shaped versus fine needle biopsy needles. They all have proprietary tip differences. So their shaft and tip design is a little bit different. The difference between the needles is ostensibly that the fine needle biopsies are meant to obtain more tissue, adequate tissue for essentially a core biopsy for histologic sampling or surgical sampling. So something like liver biopsies or something like lymph node biopsies where orientation and tissue structure is necessary, a fine needle biopsy can help with that. But in terms of cytologic examination and access, fine needle aspiration needles and fine needle biopsy needles are used similarly or interchangeably depending on the endoscopy suite. For fine needle aspiration, lesion sampling, fluid sampling, and drug delivery can be performed. The sizes of the needles tend to change, vary rather from 19 is usually the largest and 25 gauge needles being the smallest, but you can see some representative needles here in terms of the shaft tip and the orientation. So here, I don't want this to be loud. Let me see. So here is an example of extraluminal malignancy sample. This is a pancreatic tumor being sampled using an FNA technique.
This video
Yeah, how do I mute that? That was the one thing here.
depicts
We could shut off sound on the computer real fast. Thank you. Okay.
US guided fine needle aspiration of a 1 centimeter pancreatic
So
body
here
mass.
is a tumor that is being
After lesion characterization, a 25 gauge needle is selected for fine needle aspiration due to the small size of the lesion. The lesion is slowly punctured. A slow pull or capillary technique is utilized with stylet withdrawal, and care is taken to stay within the lesion.
To and fro motion into this solid tumor to access the growth and sample for cytologic analysis. Still remain muted, please. So here, when we're doing this, one of the things that we're
This
doing
video
when we're
depicts the
accessing
capillary
tumor
or slow
is
pull
what's called the
technique
slow
for
pull
US guided
technique.
fine needle
So the nurse
biopsy.
and technician,
After the lesion
when
is
an
punctured,
endoscopist
the
accesses
stylet is
a
used to
tumor,
express
will usually
gastrointestinal
request that
contaminant.
the assistant
Subsequently,
do what's called
the
a slow
assistant
pull
slowly
capillary
pulls the
technique. And what
stylet
this
back
does is
as the
creates a negative
endoscopist
suction or a
uses a
capillary
swift
wicking
to and
effect
fro
within the
motion to
shaft of the
acquire a
needle.
core
And it
specimen,
creates a
as
negative
seen
pressure
here.
so that as the endoscopist is going to and fro in the tumor, tissue is getting sucked up into the shaft of the needle to allow for expression onto a slide or into a cytologic preservative. If your centers have rapid on-site cytologic evaluation, which some do, some don't,
This video depicts on-site specimen handling for EUS-guided fine needle aspiration. In this case, a stylet is used to express the appropriate amount of specimen onto a slide.
the stylet back through the needle to express a small sample onto
The remainder
slide,
of
and
the
then a quick
tissue
sled where a
acquired
quick smear is made,
is then
and the
kept
rest of
for
the
cell
sample
block.
before that quick set is expressed into a cytologic preservative.
At this time, a
which is
second
sent
slide
to
is used to
cytology, spun
create
down,
a
and
smear
creates
as
cell
seen
block
here.
for the cytopathologist to look under the microscope for better histologic diagnosis. But here we can do quick reads.
Finally,
after
a
the
spray
slide is
fixative
preserved
is
and
used
fixed,
prior
and
to
looking
analysis.
under a microscope, determine whether or not we're actually in the area of interest. Even though we look like we were in the tumor, is everything coming back just blood or some other just kind of noise, that's not necessarily diagnostic? Or are we seeing very abnormal cells that look concerning for a malignancy, and we're in the right spot? So this is where we should continue to sample. So a good technique to use in the endoscopy suite. Similar to sampling, instead of solid tumors, we can do pancreatic cyst sampling. Pancreatic cysts really run the gamut of completely benign to possibly pre-malignant or malignant in nature. And the endoscopist usually gets referred for pancreatic cyst evaluation when a cyst is encountered incidentally on some form of cross-sectional imaging, and we want to kind of characterize what we're dealing with. So usually we'll sample with an FNA needle, although you can sample with an FNB needle as well. And once we find an pancreatic cyst on endoscopic ultrasound, we can access the collection using a needle, sample the fluid by collecting suction to the shaft of the needle, and getting a sample of fluid to send for further testing, such as cancer markers with CEA, chemical markers like amylase. Sometimes we'll use glucose, which help characterize these cysts a little bit better as well. And it can also be sent for cytology that can get spun down to look for malignant cells. Some institutions also are instituting next-generation sequencing, which looks for abnormal DNA mutations to determine whether or not a certain pathologic process is going on, such as a malignant IPMN or a dysplastic intraductal papillary mucinous neoplasm. From a nursing standpoint, it's important to understand that you should be giving prophylactic antibiotics in this setting to prevent superinfection of a cystic lesion. A new technology that we've been using, which is great, is something called the microbiopsy forceps. And this is a device that allows you to take direct histologic samples of the wall of the cyst. And so using a 19-gauge needle, they only go through a 19-gauge FNA needle, the endoscopist can access the cystic collection. And then through the needle, these microforceps can then be introduced and under ultrasound guidance, take a biopsy of the wall of the cyst. So we can get an actual histologic specimen in these microbiopsies to send off for processing so that the pathologist can help assist us and say, this looks like a mucinous cystic neoplasm with dysplastic features. You may want to consider surgical resection, or this looks like cuboidal epithelium, a benign process that we don't necessarily need to worry about. Further therapeutic interventions that we can do with EUS-FNA is palliative pain medication with celiac plexus block or neurolysis. So with endoscopic ultrasound, many times in patients suffering with abdominal pain from chronic pancreatitis or pancreatic cancer, they have severe unremitting abdominal discomfort that is requiring multiple heavy doses of narcotics. And so similar to what our anesthesia colleagues can do, we can do a pain block by doing celiac plexus neurolysis or celiac plexus block. And how we do this is using typically a 22-gauge FNA needle, a solution of bupivacaine as well as triamcinolone is drawn up by the nurse, and prophylactic antibiotics are provided beforehand. The celiac artery off the abdominal aorta is localized on endoscopic ultrasound, and using an FNA needle, this solution is injected into the celiac ganglia, which comes off the celiac artery. And we bathe these nerves in numbing solution to help afford the patient non-narcotic pain relief. Celiac plexus blocks are temporarily, they usually, if they're going to work, it'll last for about 3 to 6 months. Celiac plexus neurolysis, we exchange the steroid for something like dehydrated alcohol, and it leads to retroperitoneal fibrosis, which essentially destroys the nerves and leads to more lasting pain relief. The block is good for patients who may need surgery or may have interventions down the line because we don't want to cause that fibrosis. For patients who are completely receiving palliation and fibrosis is not a matter, that might be a more reasonable approach to give them longer, more durable pain relief. So here's a quick show here. So here is the abdominal aorta, is that long black structure towards the right side of the screen. And here you can see the needle going in, the celiac access, the takeoff is over here, not well visualized. The needle goes into this area and the technician will then aspirate to make sure we're not in a vascular area. And then as we confirm that we're not in a blood vessel or the abdominal aorta, an injection is made right off the celiac takeoff. You can see that there is a kind of a whiteout that's occurring here as the solution is bathing this area, and we get echogenic shadowing to let us know that we're also pushing the abdominal aorta away and filling that retroperitoneal space in this numbing solution and hopefully providing the patient with some form of pain relief. Great option for patients suffering with unresectable malignancy who are narcotic dependent. Switching gears a little bit, so we talked about solid tumor biopsying. One thing I wanted to break up is an exciting field of what's called endohepatology. Over the last several years, endoscopic ultrasound has been on the forefront in terms of management and diagnosis of hepatologic disease processes. So one of the things that Geisinger has been really pushing the bar with is the ability to do EUS-guided liver biopsies. So when we talk about liver biopsies in patients who have liver enzyme abnormalities that are for an unclear reason and we don't have a formal diagnosis, or patients who we are concerned have cirrhosis or advanced fibrosis on non-invasive imaging, and we want to get a confirmation to see if they're at risk for developing sequelae from cirrhosis, liver biopsy is usually mandated. And traditionally, liver biopsy can be performed externally using an IR doctor, or interventional radiologist, or a hepatologist. The patient gets a little bit of an anxiolytic. We say, hold your breath, then we shiv them in the side and take a core biopsy. They don't like it too much because they're anxious, and we don't like it too much because we can injure something. It's a relatively blind procedure where you're hoping that you're not going to hit a portal vein or vessel, but does provide good core tissue samples of the liver. Another approach that we can do is through the transjugular venous approach. So our colleagues in interventional radiology can send a probe down the internal jugular vein, get through the hepatic vein under fluoroscopic guidance, take biopsies of the tissue, microbiopsies, essentially bites through the endothelium, and then they can also do portal pressure gradient. Tissue is not as robust, and patients, again, are awake with an anxiolytic. The beauty of doing EUS-guided liver biopsy, the patient is sedated, so they get to not worry about that portion of the procedure. And also we can combine it with an upper endoscopy to look for any sequelae of portal hypertension, including esophageal varices, portal gastropathy, things that we need to worry about from that standpoint. But for EUS-guided liver biopsy, which we are routinely doing at Geisinger, we usually will use a 19-gauge fine needle biopsy needle, usually a Francine tip needle, to allow for good core biopsies of the liver parenchyma. On EUS, we'll then go ahead and visualize the liver, pass the needle through, and then use wet suction to acquire the tissue and express it on a sieve or a slide. So from a technician standpoint, when we're using this needle, it's important to prime the needle with a heparin flush. We'll flush the needle to prevent clots from forming within the needle lumen, and then apply about 1 to 2 milliliters of wet suction to the tip of the needle base. So instead of using the stylet, we'll attach a syringe with negative suction on it and create a wet suction to create a column of a vacuum to allow better tissue acquisition. The endoscopist assures that they're avoiding vasculature on ultrasound using Doppler flow, and then usually it's 3 actuations with the needle, 3 jabs, and then we express the needle, the sample on a sieve and send it off to pathology. And these core samples have been comparative to transcutaneous biopsy with similar diagnostic accuracy. So something that not every institution is doing, but it is starting to gain traction across the US. In the same vein, so we talked about our colleagues in interventional radiology being able to do portal pressure measurements to determine if patients are suffering from portal hypertension. In the realm of endoscopic ultrasound hepatology procedures here, the newer device is a portal pressure measuring gradient. And what we can do with this device essentially is take direct portal pressure measurements, not indirect pressure measurements that are done by interventional radiology. And so using a kit, essentially it's a self-contained kit, a 25-gauge needle and a transducer is attached to this 25-gauge needle. The endoscopist will visualize where the hepatic vein is and stick a needle into the hepatic vein, flush the needle with heparin, and it gives you a pressure reading. After 3 pressures, you get an average. You then orient yourself and look for where the portal vein is, find where that's flowing into the liver. Again, flush the needle with heparin after you've gained access to the portal vein, get 3 repeat readings, and then you can create a gradient and determine if the patient has portal hypertension. So this is becoming a one-stop shop. We can do upper endoscopy, screen for varices, gastric hypertension, or any type of sequelae of cirrhosis. We could do a liver biopsy to determine if the patient has the cirrhosis, and if we're concerned that they have portal hypertension or pre-portal hypertension, we can then do portal pressure sampling all in one session, which is fantastic, instead of having to micro-manage among different professions. So another new technology that is gaining traction across the US. Switching gears a little bit from diagnostic, we're going more towards the therapeutic realm, is the idea of something called an EUS-guided rendezvous procedure. And what this is using endoscopic ultrasound to gain access to either the biliary or the pancreatic system. We saw a great example of biliary cannulation by Dr. Shah a few minutes ago. But sometimes patients we can't get access due to tumor obstruction of the ampulla or due to altered anatomy. We're getting wire access to the biliary system and or the pancreatic system is technically prohibitive. And so using a 19-gauge needle, we can access the bile ducts either through a transgastric or a transduodenal approach. Use suction to confirm that we're in the system, inject contrast, flush the needle, and then use a hydrophilic guide wire to antegrade pass a wire either across the papilla or the duct of interest rather to gain access to be able to perform an ERCP afterwards. And so an example of what we're doing here, you could see in patients who have an obstruction, using an endoscopic ultrasound looking through the stomach, you can access the intrahepatic ducts, inject contrasted cholangiogram to assure that you're in the right area, advance a wire antegrade transpapillary with the wire coiling in the duodenum, and then with that wire in place, take the ultrasound scope out, advance an ERCP scope, and then get to that area and either grab the wire and perform your ERCP or cannulate alongside that area. And usual approaches are either transgastric or transduodenal. It's a relatively successful procedure, 80 to 90% of the time. Adverse events with this are slightly higher than general EUS. Most EUS procedures run the risk of adverse events such as bleeding or pancreatitis around 1% or less. This is a 13% adverse event rate. So things like biliary leak, pancreatitis, peritonitis, abdominal pain, perforation. And it has similar technical success rate to when we compare it to percutaneous access, which is how this was traditionally approved with our colleagues in interventional radiology. If we can't get access to a duct, our interventional radiology colleagues would access externally and send a wire down. We're doing this all by ourselves internally by using EUS technology. And that gets me to my next topic here is the newer invention with lumen-opposing metal stents. And one of the things that we're tasked with handling is pancreatic pseudocyst or walled-off necroses. And what this is essentially is a delayed complication of acute pancreatitis. So patients who suffer from acute pancreatitis can develop sequelae down the line 3 to 4 weeks later, where there can be necrosis or severe inflammation that the body will either resorb, but in some patients it will not. And so this persistent collection can lead to issues with gastric outlet obstruction, infection complication, pain symptoms, nausea, vomiting, weight loss. And what's necessary is a drainage of these collections to help relieve the mass effect that's happening in that situation. EUS-guided drainage has now become the first line of intervention. Traditionally, these patients would have to go for operative management, where they'd be in the intensive care unit with an open abdomen, drains hanging out, and flushing, which led to severe morbidity and increased risks of death. Now, in 2024, we have the capabilities of doing EUS-guided drainage, which allows us to use the natural anatomy to create an intentional fistula across either the stomach or the small intestine to access the collections and allow for internal drainage of the collections into the GI system. The way we used to traditionally do this is relatively cumbersome. We'd get a 19-gauge needle for access into the collection under fluoroscopy, use some sort of cautery device like a needle knife or a cystotome to puncture through the stomach or the intestine to get into this collection. Using a long guide wire through the needle, we would then coil our wire under fluoroscopy to make sure that we're in the right spot, and then inject contrast to determine the boundaries of the collection, have to dilate the opening to place a stent through, and then place a double pigtail stent and hope that goes well through every step of the line, that we don't miss access or fall out or cause an injury or bleeding or perforation. What's been invented over the last several years is something called the electrocautery enhanced lumen opposing metal stent, or LAMPS for short. And essentially, this combines all those steps into one. So this has an electrocautery enhanced thermal tip that allows for puncture into or through the wall of the intestine or stomach. And then it has a sheath stent that can be deployed by the endoscopist to essentially deploy the stent within the collection, and these stents have lumen opposing forces. So it pulls the collection towards the lumen of the GI system, and it pulls the lumen of the GI system towards the collection. And it creates a conduit for this collection to then be expressed through the GI system and pass through the intestines for decompression and expulsion. It can be done freehand or wire guided. There's several different sizes that have been approved for use. There's several steps, and I don't want to belabor going through all the steps here, but to highlight to the audience here, this is mentally intense for the endoscopist. So this is a high-risk procedure. We are intentionally drilling a hole through the intestine or the stomach to create a fistula, and any misstep can lead to a really adverse outcome, such as severe bleeding, perforation, emergent surgery, etc. So when this is happening, when we're going through this step and we're using a lumen-opposing metal stent to deployment, people are paying attention. No one's jerking around. It's all eyes on the procedure. So essentially, the steps include collection access. So with the stent, once the endoscopist finds an appropriate location, the technician will attach the system to heat, and then the endoscopist will step on the heat pedal and perforate through either the stomach or the intestine or what they're trying to access. Once that's accessed, the stent gets locked and the sheath gets pulled back, and this deploys the internal flange of the stent. Our next step is to approximate that internal flange and pull it back towards the wall of the collection without pulling it out of the collection, and then deploying the luminal side of the stent so that the stent can then be deployed and allow for drainage. So putting that all together, what that looks like on ultrasound, you can see here on ultrasound, we have a large collection in the center of the screen, a walled-off necrosis that required drainage. So I'm accessing the duct using electrocautery enhancement. We penetrate through the stomach into the collection. So now you can see the stent is in the collection. We've caused a hole. So either we're going to deploy the stent successfully, or we have a hole that we have to fix one way or another. So the stent gets deployed, the internal phalange gets exposed, and then the endoscopist is pulling that stent back towards the wall of the collection. And then, I don't know if I could fast forward this. The luminal side of the flange we are working on deploying here, making sure we're not pulling the stent out of the collection. And what you're left with endoscopically is a stent that's the luminal side, and it's going into the retroperitoneum into a large walled-off necrotic collection. We can then dilate this area to help open it up, but there you can see there's fluid and blood and other types of necrotic tissue around the pancreas that will drain naturally through into the stomach. And then we can do endoscopic nephrectomy down the line. So if endoscopic debridement is necessary for these collections, if the patient has dead tissue that is not getting expressed or getting infected that needs to be removed, we can then go in through this fistulous connection several days later and debride this area by doing a physical debridement of dead tissue, which is called an endoscopic nephrectomy, and part of our management for endoscopic necrotic collections. So currently, these lumen-opposing metal stents are approved for management of pancreatic pseudocyst and walled-off necroses, which we just saw an illustration of, and they've recently been approved for EUS-directed gallbladder drainage for patients who have cholecystitis who are non-operative candidates, meaning that they are a prohibitive risk to undergo an operation for gallbladder removal. What's been happening over the last several years is that we're finding the ability to create fistulous connections between areas of the GI system does have some other applications, and there has been off-label use of these stents, and what I'm about to discuss with you is all off-label use. I have to highlight that for you. But in terms of direct EUS-guided biliary duct drainage in patients who have malignant obstructions, we can create gastroenterostomies in patients who have gastric outlet obstructions to create a new avenue for the stomach to drain into the intestine, where they would usually require surgical intervention, or we can do EUS-directed transgastric ERCPs in patients who have altered surgical anatomy who would usually require some sort of operative assistance to get an ERCP done, who have like Roux-en-Y gastric bypass or bariatric surgery anatomy. So regarding EUS-guided cholecystoduodenostomy, this is gallbladder drainage, just to highlight it's reserved for patients with cholecystitis. It's an alternative to percutaneous, where our colleagues in IR would put a drain through the gallbladder externally, where the patient is left with a bag to drain their gallbladder. So that's one option, or there's other endoscopic options where we do transpapillary gallbladder drainage via ERCP, which is not always technically successful. So EUS-guided gallbladder drainage has shown to be technically successful, clinically successful, with an appropriate, reasonable adverse event rate comparable to the other outcomes, and more clinically successful and technically successful than transpapillary drainage and percutaneous drainage, and is really moving to the first line of non-operative management. I just had an email today from my hospital saying that we're working on our guidelines to stop these patients from going to IR and coming to us for management of non-operative cholecystitis. So it's something that's gaining traction, and something that we are now becoming the first step in terms of gallbladder drainage and non-operative candidates using this device. So here's just an example here: transpapillary drainage, percutaneous drainage, transpapillary drainage, and then a direct lumen-opposing stent through the intestine into the gallbladder. So regarding choledochoduodenostomy, this is utilized in the setting of inoperable distal malignant bile duct obstruction. So patients, this can be technically successful 92% of the time, and clinically successful close to 90% of the time. It does have a high adverse event rate where we can cause hemorrhage, perforation, biliary leak, stent migration, or infection. And essentially what we're doing in this situation is patients have a malignant obstruction that's choking off the downstream bile duct, and we either cannot put a bile duct drain in because we cannot reach the ampulla, or we cannot access because of a gastric outlet obstruction. And so instead of having a patient be destined for a permanent external drain for palliation, we can do direct drainage. So here again, you can see we're doing EUS guided evaluation. This is not a pseudocyst. This is a dilated common bile duct that we're seeing on ultrasound here. And using a smaller caliber stent, you can see on the imaging here, the patient has a duodenal stent in place for obstruction of the tumor from the small intestine. And then you can see contrast is just not flowing into the intestine. They have a complete obstruction of their bile duct. So we're using fluoroscopic guidance here to see what we're dealing with. We gained access with this lumen-opposing stent, and similar to the steps that were previously described, we deploy the internal phalange after gaining access. Sorry, I apologize for how long the video is. Come on. So there in the bottom left corner, hard to see. The endoscopic view is central, and that kind of highlights what I said about the oblique view of the endoscopic view. It's not very good. So here on ultrasound, you can see that internal phalange was deployed, and then the next step would be to deploy the luminal side of the phalange. And what we're intending on doing is doing a direct biliary drain into the small intestine for palliation in this patient who has obstructive jaundice. And so by the end of this, the stent gets released, plops out, and their bile duct now is directly draining into their small intestine. Pretty awesome. Moving on from that, we can use these stents off-label, again, for what's called EUS-guided gastroenterostomy. This is an alternative to enteral stenting or surgical bypass in patients who have a gastric outlet obstruction, and it can be performed either freehand or balloon-assisted. I don't have a good video for this, but essentially it requires distension of the small bowel, and that on endoscopic ultrasound, we target this area through the stomach like a balloon. We look for it like a pseudocyst collection. And us deploy a larger caliber lumen-opposing metal stent to create a fistulous connection between the stomach and the small intestine to allow for bypass of food contents beyond the gastric outlet obstruction. Technically successful about 90% of the time, clinically successful close to 100% of the time. Maldeployment of the stent is the most common issue where we can deploy intraperitoneally, which may lead to an emergency surgery. So this is a high-risk procedure. Sometimes, as long as the bowel isn't injured, these perforations can be managed endoscopically. However, there is a potential risk for causing a bowel perforation that can lead to emergent surgery. But it can reduce the need for reintervention compared to traditional enteral stent placement, and it may have less adverse events than surgical gastroenterostomy. So, here's a cartoon of essentially what we do. Endoscopically, we fill the lumen of the small bowel with methylene blue or some sort of contrast-enhanced solution so that we can access it, drill a hole through the stomach into the small bowel using this lumen-opposing metal stent, and create a fistulous connection between the stomach and the small bowel. And what you're left with is a new outlet from the stomach to circumvent that gastric outlet obstruction. The last technique I wanted to highlight in terms of new uses of these lumen-opposing metal stents is something called EUS-directed transgastric ERCP, or the EDGE procedure. This is reserved for patients who have Roux-en-Y gastric bypass altered anatomy. And so looking at these illustrations, on the left, you can see traditional normal anatomic orientation, and on the right is gastric bypass or Roux-en-Y gastric bypass orientation, where the gastric pouch then gets isolated from the rest of the remnant stomach, and getting to the duodenum, which you saw in the ERCP, we have to go transorally to get to the duodenum, is prohibitive because surgically their anatomy is restricted and we can't access that region. So traditionally, patients would either have to go for what's called a lap-assisted ERCP, where they go to the operating room and a trocar is placed in the remnant stomach, and then an ERCP can be performed through the trocar with that in the operating room. Or we can do balloon-assisted ERCP using a balloon enteroscope, which is technically and time demanding, very challenging, where we just snake a very long scope down to where the roux limb is, climb back up, get to the ampulla, and do an ERCP in that fashion. Using EUS-directed transgastric ERCP, this allows us to get EUS-guided access to this remnant or excluded stomach, and then do an ERCP right through the stent. So kind of a cartoon of what we're visualizing here. Using this stent, we create a fistulous connection between the pouch and the remnant stomach, and then can perform an endoscopic retrograde cholangiopancreatography like we traditionally would, using the stent as a conduit to get to that previously inaccessible anatomy. Technically successful 96% of the time, clinically successful 91% of the time. The adverse events, again, high, close to almost 20%, mainly from potential reversal of the surgery. So afterwards, after we do this procedure, you've essentially reversed the patient's surgery and need to close the hole that you made, and that can happen down the line after the procedure is completed. But stent migration, bleeding, perforation, pancreatitis, all can be adverse events associated with this as well. So the way this is done, you access the gastric remnant using a 19-gauge needle. We inject saline mixed with contrast and methylene blue into this remnant stomach to distend it open like a balloon. We deploy this lumen-opposing stent across the pouch into the gastric remnant, dilate the stent to allow us to pass our next device, can anchor the stent using sutures or clips so that it doesn't fall out during the ERCP. Do the ERCP, come out, and then remove the stent 6 weeks later to allow that area to fistulize and then close that fistula endoscopically, either surgically, or sorry, with sutures or with combination of over-the-scope clips. So the last video I have for you guys, here you can see in the top corner, this is us using a 19-gauge needle to access that remnant stomach, and we've distended it open to create a target for us to create a drill through. So we're in the pouch, the remnant pouch. Oh, I'm sorry about that. So then the lumen-opposing stent is used to gain access. We created a hole through the pouch into the remnant stomach. We're deploying this large lumen-opposing stent with the internal flange in that isolated stomach, and then deploying the other end within the remnant. And so endoscopically, what you see, we get down into the gastric pouch, and you can see we have now made a new access to the remnant stomach to be able to use the patient's traditional natural anatomy to perform an ERCP the way we traditionally do. Here we're dilating the stent to allow our device to pass. The ERCP probe is around 12 to 13 millimeters in diameter, and this is a 20 millimeter lumen-opposing stent. So we dilate it up to allow us to pass our scope, and then after dilation is performed, we can then access the remnant stomach that was previously isolated due to the patient's surgery, and then using an ERCP scope, we can advance to the papilla like we normally do and go ahead and do an ERCP for something usually like a stone case in a patient who has a retained gallbladder after their Roux-en-Y gastric bypass and now is suffering from gallbladder stones. But again, allows us to do everything independently in the endoscopy suite without the need of using our surgical colleagues or without the need for interventional radiology. And here we're just doing an ERCP like we just saw, which is great. I don't know if I have closure left. And then afterwards, we allow the stent to stay in place for about 6 weeks to allow that area to scar down and fistulize, remove the stent so that we don't create a perforation about 6 weeks later, and then close it endoscopically using suturing techniques or clip closure. So kind of a whirlwind of procedures that we do, but going from super basic with our needles, biopsy needles and aspiration needles, as well as our, oh, there is a closure video, as well as our more advanced technology that we're using with these lumen-opposing stents, and that we're getting into the realm of third space endoscopy, creating connections between areas of the isolated GI system that we were previously unable to access without assistance with our surgical colleagues. So ultrasound has really taken us into a new realm of endoscopy, and the region of therapeutic ultrasound is very exciting, and right now seems to be really at the forefront of natural orifice intervention. And so here's just an example of closure of the access afterwards. But that's the last slide I have for you guys. Thank you for your time and attention. I appreciate that. And if you guys have any questions, happy to entertain them at this time. Yeah, no. Thanks. Thanks for your help.
All right, everybody. So we actually get to watch an ultrasound next for a live case, but we're not going to start that for a few minutes. So we have a little bit of a break, about 15 minutes. If you all need the restroom, it is out to the left. Please be back by, or sorry, I said 15 minutes, I meant 10. Please be back around 9:30, and then hopefully we'll get started with that ultrasound. Thank you so much.
Dr. Wani, can you hear us in the conference room here? Okay, so yeah, so they're on a 15-minute break. They asked them to come back at 9:30. We'll have the slide deck up, the case slide deck. So
Oh,
we'll be
boy.
ready to present that, and then we'll move right into you live.
Might be too close now.
Okay, that
No,
sounds
you're-
great. Thanks. Yes.
Oh, you want that?
Yeah.
Okay, well,
Endo.
that's going to take a second.
Yeah, that's okay. Endo?
Oh, please. Nope. Ah, shoot. Okay. Go ahead. Do you want ultrasound now?
Yeah.
I got to go back. I have to. 2
Okay,
seconds.
sure.
She's adjusting something too.
All right, everybody, it looks like we are starting a little early. So as you're coming in, please go ahead and take your seats. We'll have Dr. Shaw up here to kind of narrate what's going on with this ultrasound here shortly.
Hey, Sechin, so you know that you're on camera. Okay. It's okay. People are just filing in now, but I just wanted to let you know so you don't do anything silly. But it's good that you kept your tie on and no scrubs. You really outdid me there. You look great on camera, by the way. If this endoscopy thing doesn't work out, maybe I don't know, news? Would you do the news? It's election year. And I know you can't respond, so that's good. We can't hear you.
So, Raj, just let us know when you think you're ready to go live, okay? I mean, I know I'm on camera, but when you're ready to do the case presentation.
We have Josh here too.
Terrific.
Hey, Sachin.
Should we wait?
Hey, bud, how are you, man?
Great, bud. There's some people.
I'm so glad you made it.
Wait. Oh, okay.
Is it the presentation? Oh, sure. Sachin, we're just going to have the case presentation get set up on the screen. We can go through it for the audience here. So it looks like
That's great.
We have a 60-year-old male with unintentional weight loss was found to have a pancreatic mass on imaging. CT was performed showing an ill-defined 4.3 centimeter growth arising from the head of the pancreas with mild pancreatic ductal dilation to about 3 millimeters and atrophy of the upstream body and tail. The mass was appeared to surround the celiac axis as well as the common hepatic and splenic arteries, as well as the superior aspect of the superior mesenteric vein and narrowing and occlusion of the distal superior mesenteric vein and portal vein. Numerous large portohepatus collaterals were present. Labs had no abnormalities in terms of cholestasis or abnormal liver testing, and the patient was thus referred for endoscopic ultrasound for tissue sampling in the head of the pancreas.
Thanks, Josh. Can you guys hear me okay?
We can hear you. Can we cut back? We can hear and see you pretty well, Sachin.
Awesome, awesome. So thanks for the case presentation. Again, I have two amazing individuals helping me with this case. Christy and Amy are in the room, and Sunita is providing anesthesia for this patient. Really nice, pleasant gentleman who's presented with a pancreatic mass. So what I'd like to do in these next few minutes is just go over a few basics in terms of the stations that we typically look at for patients presenting with any pancreatic or biliary abnormality. And what I'm doing right now is really inspecting the left lobe of the liver. The whole idea for an endosonographer is to provide accurate staging apart from providing the accurate diagnosis for the mass that this patient has presented with. And this was something that I was taught as a trainee. One of your primary goals is to not just provide the accurate stage, but to really ensure that you've looked at not just local staging, but also to rule out metastatic disease. So you're really scanning the left lobe of the liver to ensure that there is no metastatic lesion. And before we went live, I looked at the left lobe and I really did not see any obvious metastatic lesion. So you look at the left lobe of the liver with your echo endoscope in the proximal gastric body and sometimes in the mid body as well. And then, of course, we'll take a look at the liver when we go down to the duodenal bulb as well. The next station that you need to focus on is looking at the aorta and looking at the celiac axis. So what you can see here, and in this patient, the aorta seems to be a little distant, but that's okay. And you can see the aorta. Raj, do you have your pointer on?
Yeah, I'm gonna try it right
Okay.
now.
So okay, so you can see the aorta, and then you can see the celiac takeoff, and just below that is the takeoff of the SMA. Josh, Raj, can you see that below?
Yes, we got it.
We're just getting excited
Okay.
about the technology, so we have a little hand here.
Got it. All right. So now that we've seen that, I'm just going to pass my scope down to inspect the pancreas. And right off the bat, just for the audience, when you inspect the pancreas from the gastric body, you're really inspecting the pancreatic neck or the genium, the pancreatic body, and pancreatic tail. So these are the parts of the pancreas that you will visualize. And a normal appearing pancreas will have this salt pepper appearance, and in this patient, as you can appreciate right off the bat, you can see an area that does not look right. You can appreciate the fact that there is a hypoechoic area. So solid pancreatic masses will have a hypoechoic appearance on EUS, and I'm sure Josh went over all of that in his presentation. Right to the side is one of the splenic vessels, and now what I'm doing is two maneuvers. One is I'm going to move my scope to the left, so I'm dropping my left hand, and you can see more of the pancreatic neck, and you can again appreciate that there is a hypoechoic appearing mass in the neck region. Now, what I'm going to do is, and by the way, you can, Josh and Raj, if you can also show where you would see the splenoportal confluence, and you can see that the tumor does appear to be invading slash abutting the splenoportal confluence.
Hard
You
to
guys see that?
hard to see the
Hard to
splenoportal.
appreciate.
Yeah, hard to appreciate the SPV there, or the SPC rather.
I'm glad he had a hard time.
Right there.
Oh, there it is.
Okay.
I could. That's a little bit better there.
Yeah.
Yep, yep.
Yep, exactly. And then what I'm going to do is I'm going to lift my left hand and now go towards the proximal body. And again, you can see the hypoechoic mass, which is what I will be targeting when I do sampling. And I'm torquing my scope to the right. And again, you can see the pancreas. And I think one characteristic that you can appreciate right off the bat is you're not seeing that much pancreatic parenchyma, right? So this patient has pancreatic atrophy, which we see typically in patients with pancreatic tumors, specifically patients with pancreatic ductal adenocarcinoma.
Is
And now you
sorry,
can see, Raj, were you saying something?
sorry to interrupt. Is there a calcification there too?
Yep. Yep, you're
Do you have
right. I
known
was going
chronic
to say
pancreatitis?
that. Yeah.
Do you know?
No, no history of chronic pancreatitis. I wonder if these are just changes within the tumor. So sometimes we can see a heterogeneous appearing mass at times as well, but no prior history of chronic pancreatitis. But that's a really good point that Dr. Shah is making, because remember that chronic pancreatitis is a risk factor for pancreatic cancer. And also important to recognize that patients, when they do have malignant transformation in the setting of chronic pancreatitis, detection of early pancreatic cancer changes can be challenging. As I'm torquing my scope to the right, you can also see the pancreatic duct. I'm going to freeze and show you a nice image. And there might be some isoechoic material right within the pancreatic duct. So this is the pancreatic duct. And Raj, can you also show the filling defect within the pancreatic duct?
The slide you're talking about there, Sachin.
So just to the left of my, hold on one second.
I could.
So right here,
Yes. Yeah.
yeah. Do you see some material within the pancreatic duct?
Little hard for us to see.
Yeah, it looks hard to see if it's shadowing or if there's just some. I'm sure there is some.
Yeah, no shadowing.
Yeah.
I wanted to get a survey from the audience as to who or how many of you do endoscopic ultrasound in your endoscopy labs or hospitals? Show of hands, please. So only a few, maybe less than a dozen, actually. Some of them
Yeah,
work
yeah.
here, so I
Hmm, hmm.
they
So that's good. They'll believe what I'm saying then.
that's really why I asked the question.
Yeah. All right. So what you can see just below the splenic vessel is the pancreas, and it's atrophic, and you can see PD dilation upstream to the pancreatic mass. Can you guys see that? Okay.
Yes, we do. We can point that
Okay.
one out.
Terrific.
Thanks, Sachin.
Yeah, of course. So that's what I've seen so far. And as I tell the trainees as well, it's really important to take the time to make sure that you torque all the way to the right so that you can see the spleen and the splenic hilum. That's one way that you can confirm that you've really inspected the entire pancreas. The last thing you want to do is miss a lesion of significance in the pancreatic tail. So that's the inspection from the gastric body. Any questions so far?
Yeah, Sachin, it looks like he does have a lot of venous collaterals when you were going towards the splenic area in the setting of that splenoportal confluence obstruction.
You got it. Exactly, exactly. So we'll have to be super careful, find an avascular plane like we do for all cases, and confirm that we're not going to hit any of those dilated blood vessels. So now the next step is, Josh, now I'm in the duodenal bulb. And what I'm doing is really focusing on identifying three important structures here. One is the bile duct, the portal vein, the splenoportal confluence, and see if we can provide any additional information in terms of staging. So I'm going to turn my flow on because that's how you get some idea of the structures that you're looking at. And you can appreciate exactly what you were saying earlier, Josh, that there are a fair number of collaterals going towards not just the splenic hilum, but also towards the porta hepatis, which you brought up during the case presentation as well. Can you see those blood vessels?
Oh yeah, they're looking pretty ominous.
Yeah.
I hope you have a good target.
Yeah. So now that you've seen that, I'm going to go back into the bulb and see if we can identify anything else. I think I can see the common bile duct right here. Just give me 1 second. It's between these vessels here. So just give me a second and I'll show you the common bile duct. Josh, do you see that?
Yeah,
Raj?
pretty buried in between those collaterals there.
Yeah, yeah. So, but this is important to note because this confirms what we've seen, right? That the patient has a body slash genu mass and not really involving the head of the pancreas. So, I don't know if you appreciated the fact that I'm also demonstrating uh, the pancreatic head, common bile duct, and going towards the ampullum.
No, a lot of anatomic distortion with those vascular collaterals, but you're doing a great job identifying critical structures here. Are you able to
Yeah,
see
yeah.
pancreatic duct in the head there?
That, yeah, that's what I'm trying to see here. That was the next step. You're right. It is challenging, isn't
Yeah,
it,
and
with
that might be
all
over
these vessels?
over here. It looks like that might be the ampulla or the pancreas. Oh, you can't see what I'm pointing at, but the on the where you were
Yeah,
rotating, I think I saw the ampullary takeoff.
yeah, yeah. I mean, I have gone back and forth towards the
There
yeah.
it is. Yep.
Okay. Yeah. So I wonder if the pancreatic duct is coming down below here, and then I'll take it up to the ampullum.
I'm glad I got the
But
stone case, Sachin.
you planned it, didn't you? Okay, so there, Josh, I think you're right. So I didn't know if you saw that, but that's the pancreatic duct going down.
Yep.
As I dropped my left hand, typically you should be able to see the pancreatic duct going down, what we call as the waterfall sign. And that's the pancreatic duct going towards the ampullum. And this is important, right? Because you've now demonstrated that there's no biliary dilatation, and that explains why his liver function tests are normal. I think as the cancer advances, we've seen genu or neck lesions also cause biliary obstruction, and typically the obstruction is in the mid to lower portion of the bile duct as the tumor sort of invades into the surrounding structures and bile duct. So that pretty much finishes demonstration of all the stations. Raj and Josh, anything else that you want me to demonstrate before we move towards sampling?
I just, to reinforce, I forgot whether or not you cleared the undersurface or the right side of the liver in the bulb to make sure there was no evidence of oligometastatic disease.
I did, but let me show that station one more time. All right, so now I'm in the bulb again, and you can appreciate again what we have demonstrated a few times, fairly large varices. And as I mentioned earlier, so when you need to move towards the hepatic hilum, what we do is drop our left hand, and that takes you towards the liver.
Very nice.
So, Josh, I did not see any evidence of metastatic lymphadenopathy in this region. I did not see any obvious metastatic lesions in the liver in this from this station either.
Fantastic. Thank you for redoing that.
Yeah, no, of course.
So,
Okay.
Sachin, you may have
So-
said this, but these collaterals usually are suggestive of invasion. You mentioned that? Like portal vein
Yeah.
invasion, that these
Correct.
kind of cavernous transformation of the portal vein, it might make or would make surgery probably impossible.
Yeah, yeah. Just wanted to demonstrate the gallbladder as well. And I'm sure Josh talked to you about EUS guided gallbladder drainage, and this is something else that you know, a major advancement in what we can do as endosonographers as well.
I'm
Not
glad he
indicated
covered
in
that.
this.
Otherwise, you would have made him feel really bad.
No, thanks, sir. Thanks. I
No,
think
no, he did.
yeah,
I would never throw Josh under the bus. He's a good guy. I like him.
So, for the audience that doesn't perform endoscopic ultrasound in their facilities, could you, as you're getting the needle ready and stuff for sampling, could you comment on, well, choice of needle, but also indications for pancreatic
22 charcoal.
EUS? What are the main indications, and where do you find it useful in your practice?
And
Hold on one second, Raj. Josh, do you want to take that? I'm just getting
Sure,
the
sure.
needle
So,
and all of that ready.
as we covered in our topic a little while ago, so for endoscopic ultrasound for diagnostic purposes in the setting of a pancreatic mass, we were talking about the difference in radial probes and linear probes. Right now, Dr. Wani is using a linear probe with the necessity that he has to do extraluminal tissue sampling, right? There's a potential mass in the pancreas that he needs a diagnosis, and the radial probe, while it could see a mass, wouldn't necessarily be able to sample that as such. And then in terms of needle choice, I'll be interested to see what Dr. Wani chooses for his needle of choice in the setting of these collateral vessels, what he may go for. And then Sachin, I'm assuming there's rapid on-site cytologic evaluation there today. Excellent. So we'll be able to see that live as well.
Yeah, Josh, not much has changed since you finished your training.
That's good to know. Well, this beautiful
Yeah,
building wasn't
we
here.
still,
I mean, geez, you guys waited for me to leave to put something like this up. This is amazing.
yeah, so we do have on-site cytopathology evaluation, and we've done quite a few studies looking at the types of needles that you should be using in terms of sampling, and our approach really has changed in terms of really moving away from FNA needles. We typically use FNB needles just because of multiple reasons, right? One is that it allows us to get good architectural evaluation of the sample or the mass that you are going after. You could potentially get your diagnosis fairly quickly, less number of passes. The other thing I will tell you though is most studies that have compared FNA to FNB have really shown no difference in the overall diagnostic accuracy. But all these added advantages that you have by using FNB needles, you get a core sample. So if you need to do additional evaluation, whether if it is further evaluation for lymphoma or neuroendocrine tumors, or using these samples for further testing for biomarkers or genetic testing, you can do all of that with these core specimens that you can get with FNB needles. So it's a little challenging to get this lesion in a position where I don't have the collaterals, I don't have the splenic vessels in my view, but I think I have the mass in view, as you can see from somewhere in the 5 to 6 o'clock position. Would you
Hey,
agree with that?
Sachin,
Yep.
could you,
Yep.
they had that second camera. Let's go back to grid view here. We just want to be able to see the second camera that's on a boom, I think, or no, from the back.
Okay.
There's that second
Can
camera
you
because we
hold
want to
the
see your
scope for a
hand
second?
and also the let's
Slide
see.
expression.
Yeah. Well, I have it on grid view. We just want to be able to see that second camera here. It's not on right now. But I guess you could do your first pass so we can show for the second pass what we can
Oh,
we can
sure,
see you a
sure.
little bit more now in the needle. Okay. Thank you.
So,
Okay,
Dr.
yeah.
Wani, you nicely explained your reason for using a FNB needle in this situation. I could see you've grabbed a fine needle biopsy needle. What size are you using?
I'm using a 22 gauge, Josh, but I do tend to use 25 gauge needles if, I'm concerned about, having a blood vessel in my needle path, or, if I'm going after a lymph node. Those are times where I would consider using a 25 gauge needle. So just give me 1 second here, guys. If you can just hold the scope there, please. Let's bring it back a little bit. There you go. Hold it right there.
Well, while Dr. Wani's lining up, there is a question from in the
Okay,
chat. I'm
just
not
hold it
sure where
right
the
there. You're pulling on
chat is
it a little
housed,
bit.
but
Okay.
this is the question. It
Pull on
says,
it some more.
mind fielding this?
There you go.
For Edge, how do you mix the saline contrast methylene mixture and the quantities of each? And do you just hook up a rapid refill
Okay,
to
ready?
fill the excluded stomach?
That's an interesting question. So usually when I'm distending the abdomen,
Do you want to explain what Edge?
we did on the last.
Oh, you did already?
Yeah.
Oh, fantastic.
So when we're doing EUS directed
Okay, hold on 1
transgastric
second.
ERCP for the bariatric surgery
Okay, hold it
patients,
right there.
usually
You're
when we're
holding the
distending
scope?
the stomach, I'll usually
Thanks.
dilute the contrast to about 70% with saline mixture, and it's not a hard and fast objective measurement. It's usually an eyeball. 70% contrast, 30% saline solution, and then usually about 1 drop of methylene blue, just to kind of let us know that qualitatively that we're in the area of access. Because when you're doing direct transgastric access, the concern is that you may injure bowel. And what you want to see is that when you're aspirating in the isolated stomach, that you're getting color change back to make sure you're not either in the colon or the small intestine. But thank you for the question. So it looks like, Dr. Wani, you're in the lesion here. We can see your needle at the top right portion of the screen, that hyperechoic area, and doing that to and fro actuations here within the tumor itself. And your technician is doing it appears to be a slope. Oh, you haven't slope pulled yet? I can't see if your stylet's still in.
It's out.
Okay.
Yeah, the stylet is out now. And, typically I try and do a fanning technique. Go ahead and suction on off.
Christy, could you
I
point
try
out
and do
what
the
you did
fanning.
with the stylet? How you curled it up and where you keep it in your hands, or do you put it aside?
No, I keep it in my pinky. And I just kind of loop it as it goes so that I don't
So
come back and hit him.
for this specific needle, what you do is really almost like flick the needle away from the handle. And this needle really allows you to use different bullet gauges. If you decide, while you're doing the procedure, okay, 22 gauge is not working, I prefer to go with a 25, you can just get another bullet and put it through this handle. And I'm not, and I'm being very cognizant and intentional about how I'm sampling. As we discussed earlier, there are a lot of collaterals. So of course I'm watching and ensuring that there is no bleeding after my sampling. I think it would be a good idea to see how Christy's handling this sample next.
Sure, let's see.
If Christy looks
Raj,
to
do
that
you see?
camera and says, "Track me," they'll actually track her voice.
Oh, not that one. Oh, track me. I don't think I'm over far enough. Track me.
Earliest phases of AI, maybe.
So just to explain to the audience, so what Dr. Wani was saying about the bullet exchange, so this needle's a little bit different, where you can remove the sheet that has the needle in it itself. For most traditional EUS-guided FNA or FNB needles, the entire device gets unscrewed from the operating channel and then gets removed off the device, which you can do with this, but he chose to remove the needle bullet. But most of them, you have to remove the whole device off the scope.
Yeah, and while we're waiting to process this sample, Josh, did you cover the different types of FNB needles in your talk? I'm sorry if I missed that.
I briefly did, but there is a question in the audience that we might want to field if we can.
Sure.
Hold on for
Are they here on site? Yeah.
I was going to do the sample.
Yeah.
Do we need to repeat them? Everybody hear the question?
So I think the question was, when we're using endoscopic ultrasound, what do we mean by terms of hyperechoic, hypoechoic? How do we determine the difference between a solid lesion versus cystic lesion? Sachin, if you're busy, I could take that, or if you'd like to field that.
Yeah, please go ahead, Josh.
Dr. Wani on ultrasound here, he's when we say hyperechoic, we mean essentially endosonographically bright. So the image is bright. And then when we say hypoechoic, it's the alternative. It's darker or less intense than the surrounding tissue. As we discussed about the different acoustic velocities at the very riveting
Chrissy, did we get anything?
But the changes in velocity of sound can create the differences in echogenicity in terms of the tissue that you're looking at. So when you see a lesion that is hypoechoic relative to the rest of the parenchyma, that is concerning that it may not be benign, it might be a neoplastic process. In terms of whether or not something is cystic, we see something called anechoic. I mean, it's completely black. So the transition between the wall of the cystic lesion and the contents of the cyst become black, we can then use Doppler flow, which when Dr. Wani was looking at the collaterals, he's using the processor to see where if there's flow within these anechoic structures. So the ability to determine whether or not, you can see in the top right hand of the screen over there's a blue flow there. He's got his flow on. So that thing that is anechoic is actually a blood vessel. So there's flow going through it versus something that doesn't have flow in it. There's either no blood flow or it could be a cystic lesion or a structure such as the bile duct or the pancreatic duct, which is how he was able to determine such.
Send any material or no?
It went in cell block.
It went into cell block? Yeah, and Josh, in terms of the needles, obviously you have a needle that has the reverse bevel design, you have the Franzine needle design, and then you have the fork tip needle design, right? And the needle that I use has a fork tip design.
Thank you.
Any thoughts, preferences in terms of what you use in your practice, Josh?
I tend to use
Raj?
I tend to use a 22 gauge Francine tip needle. That's just what we are stocked with in our endo suite for the most part. Honestly, I still use FNA needles if I think that the lesion is low hanging fruit and the cost is going to be cost effective to use an FNA versus an FNB needle. So we will use an FNA needle occasionally if it's a straightforward sampling and the architecture is not necessarily something that we're worried about and we're confident that we're going to get good samples. From a cost-effective standpoint, it seems that it would be behoove us to use that occasionally. But for small or hypervascular areas, I will tend to use a 25 gauge because I'm worried about collateral vessel injury.
Could we ask you another question, Sachin, from the
You bet.
audience? It's not
Yep.
EUS related.
Sure.
Or Josh, maybe you could take it.
Sure.
Okay, go ahead. Slow pull.
Mhm.
And guys,
or
can
feel
you
free,
see
I can
how
ask
Christy is doing a slow pull?
Yeah.
And that uses the capillary technique or principle to collect cells and tissue from the pancreatic mass.
We can see the hand moving. A little hard to see the thin stylet, but we get the idea. So thanks for bringing that
Yeah,
up.
yeah. Yep, of course. Okay, can you just hold it right there?
Christy, any
Yep.
pointers to prevent accidental needle puncture or getting stabbed with a stylet that you could share with our audience?
I just always try to make sure that the doctor has locked the needle before I go to grab it from the scope. This one's nice because this needle has a sheath on the end of it so that when it comes out, it's protected. But I always make sure that they lock the dials and that it's pulled all the way up to 0 before I watch them disconnect it from the scope so that I don't get poked.
Yeah,
Can you
that's
just bring
that's
the
a good
scope? Yeah,
point there.
yeah.
And you could see on the needle probe itself, there is a locking device that Dr. Wani has disengaged so that he can do actuations. But you could see here in that orange
no.
area, that is the lock
Can you hold
stylet.
it right
So
there?
if that's all the
Talk
way
to the
up
right.
and locked at the top of the scope, it prevents the
Oh.
needle from getting
Oh, no.
Suction.
Yeah.
getting
Hold please.
expressed from the sheath so that you don't have an accidental needle stick. So
Hold on.
very important from a nursing
Yep.
standpoint, if you are transitioning these needles, to assure
Okay,
that the wire
ready?
is locked
On.
before handling it
On.
or passing it off to another
Okay,
physician.
perfect.
or
No, keep it
technologist so
on.
that you don't have an accidental
Just
needle
because
stick in the
one more
endoscopy suite.
tissue
Yeah.
now.
And I think Christy also mentioned, the importance of closed loop communication. So, when I'm certain when you're expressing the contents onto a slide or into a preservative for cell block, that you are saying that the needle is coming out before placing the needle coming out. So having closed loop communication with the doctors and the technicians in the room will help keep the room safe when you're doing these types of procedures.
I don't know how far they are in terms of potentially showing you our first pass and what that shows. But what I'm doing and what Christy and I are doing is I have to keep moving the scope back to stay in position so that I'm really getting a good pass across the pancreatic mass.
And Satya, are you using dry suction or wet suction for this?
Dry.
Dry suction.
I don't think there's any good data demonstrating a significant advantage of using wet over dry, at least the last time I had reviewed the literature for this.
Yeah, I agree. I tend to use wet. I find it tends to be less bloody for one reason or another, but I agree. I don't think I think it's kind of dealer's choice.
That's a Geisinger thing, huh, Josh?
It's a Geisinger thing, yeah.
You never did that here.
There, you're right.
I
Will you?
know I talked about tissue like that, but in terms of wet.
Okay. Do we have the first pass to look at? Can we look at the Hall microscope? And can you please also call them that we have a second pass that's ready?
Is it getting teed up there, Sachin, for us to view the pathologist and all
Yeah,
that?
I'm hoping.
There
I'm
is
hoping.
there is a non-EUS question. If you have a
Yeah.
moment to field it,
Of course.
or we can talk about it.
Yeah, you can remove scope.
So the question is,
Mhm.
Yeah.
I'll wait till he's got.
Hey, what do you see? Okay. Yeah, sure. It's a pancreatic neck and proximal body mass. I have another pass. Stomach. Yeah.
So it sounds
Symptomatic.
like his first.
So Dr. Marshall is in the room, and she is our expert cytopathologist, and she's going to provide a read on the passes that we've obtained. I'm just having a communication with her and discussion about what we're seeing on EUS, because that clinical information is really important for them when they review slides as well. So I just went over the history with her. Obvious, yeah. So I know a lot of material went into cell block. So maybe this next one we can just possibly just create more slides to get the diagnosis. Yeah. So Raj, what was the non-EUS question? Sorry about that.
It was the question. Let me pull it up here. It's on a chat. I'd encourage everyone if you could use the microphone for questions. I think it'd be a little more interactive, and we're all here to learn, so no problems asking any question. But this is a question. It says, now with advanced technology, do we see less pancreatitis post ERCP?
Dr. Wani,
Sachin?
I know this is an ultrasound that you're doing.
No, I'm sorry, I couldn't hear the question completely.
Okay, it says now.
I mean, literally, there was a pause in your comment. So that's why I was looking at Christy, whether she heard the entire question or not. What was the question? Would you mind repeating it?
Now with advanced technology, do we see less pancreatitis post ERCP?
I'm not sure if advancements in technology has resulted in a reduction in the rate of post-ERCP pancreatitis as yet, but that's a fantastic comment and question, because so much work is being done in terms of reducing post-ERCP pancreatitis, and this includes appropriate patient selection. I think that's the number one thing that we can all do as healthcare providers to ensure that we do only ERCPs in patients who absolutely need it. The second thing I would say is who's doing the ERCP is also important. You want to ensure that the person doing the ERCP is adequately trained and has an adequate number of ERCPs that he or she performs on an annual basis. With regards to the technical aspects, I think the biggest advancement has been the use of wire-guided cannulation that Dr. Shah demonstrated, the use of fluids during the procedure, and the third being the use of rectal indomethacin. So I would say these are the main things that we can all focus on to minimize the risk of post-ERCP pancreatitis. pancreatitis. What I will also say is, in terms of advancements, there are a lot of models that are being developed to identify pre-procedure who are patients who are at the highest risk for post-ERCP pancreatitis, and models that incorporate technical aspects to also predict the risk of post-ERCP pancreatitis. I think
That's an
we
excellent
have,
response, Sachin. Thank you. I wonder
yeah,
if
of course.
the pathologist could, are we
Yeah,
using
we actually have the slides teed up. Do you see it?
Oh yeah, I see it's
And
great.
Well, not pretty for the
can
I mean,
someone let
great in
Dr.
the sense
Marshall
that
know?
the colors are nice.
not great for the patient.
She's mic'd up.
I hope so.
Yeah. So it's like for the audience as we're waiting, there's a lot of blood cells in the background. We can see those small red things are blood scatter, and then a simple mnemonic that we learn in training: blue is bad. So usually you're looking for enlarged nuclei or mitotic figures or large cytoplasm or nuclear to cytoplasmic ratios with very large nuclei or nucleoli. That would be concerning for a possible malignant process due to rapid cellular division of this malignancy. So I don't want to speak on the behalf of the cytopathologist, but maybe we can.
I think we're done, Sachin, but we're waiting. What do you think?
Yeah,
You
yeah.
think we're done?
Uh,
That's our
no, I'm not
prediction.
sure. I mean, there was one image where I saw a really large cell,
Yeah.
but there were some that also showed just maybe contaminant or acinar cells.
It seems like
Like,
there's
see,
some
this is not cancer.
nucleomorphism.
Yeah, yeah, yeah,
Here,
yeah,
like the
yeah,
nuclei are
yeah,
different. The purple blue, they're
yep,
different
yep. You got
sizes
it.
with quite nuclear variability. Unfortunately, we were all untrained in this. We're always biased too. We always think we're done after
Yeah.
one or two passes, but often we're wrong.
Yeah, agreed.
Yes, yes, please. Can we have Dr. Marshall mic up? I'm sure you guys would learn something from her. Dr. Marshall actually has been with us for over a decade now, and she's actually been a part of several of our EUS sampling studies that we've done. Oh, good. Okay, thank you. So we just heard from our cyto tech that the sample is diagnostic for adenocarcinoma. So this is also one other advantage of having an on-site cytopathologist. I talked to the patient before the procedure, and I assured him that we'll give them at least some preliminary diagnosis after the procedure. So, but I do really emphasize that it's a preliminary read, and sometimes the diagnosis can change after they get all the results available. Do you know if Dr. Marshall is mic'd up?
I think so. Can you hear me okay?
Yeah.
Yeah,
Hey, Carrie.
we can hear you, Carrie.
Hi.
Thank you for doing
Sorry for
this.
the difficulties. So yeah, the second slide is much more cellular and gives us a lot more things to look at. I've kind of zoomed in on a group here that is really consistent with malignancy and a diagnosis of adenocarcinoma. There's a group of epithelial cells here, and right there in the center is one really large cell. And so one of the criteria that we can really hang our hat on to call something malignant is if there's a size change in a 4:1 between cells within the same group. So this cell has a neighbor to the like 9 o'clock position that definitely could fit four of them into that big cell. So this is consistent with adenocarcinoma. A little bit earlier, I was kind of looking around. There were some chunks of very thick mucin. And while that can come from the stomach that we're passing through, it's also indicative that this may have been a pre-existing mucinous neoplasm that has kind of degenerated into an adenocarcinoma. There were also a few groups of more fibrous tissue that is typical in tumors when there's kind of a desmoplastic response to tumor. So again, here's a little bit of that mucin material. Here it's very kind of wispy and stringy. And some folks feel like they can tell when mucin is from tumors versus stomach. I don't think I'm that confident, but it definitely brings up the possibility of it being kind of a mucinous lesion as a precursor to this carcinoma. Let me see if I can find that group of fibrosis again. Here's a little bit of it. So in these slides, they definitely look fuzzy. I realize that folks are not typically cytopathologists, but the reason that they're fuzzy is we're looking at them so quickly, we don't even take the time to cover slip them. So when we go on a high power like this, everything gets a little bit more fuzzy. But this really dense pink material that's kind of stringing out, that is fibrosis within the pancreas. So again, that's pretty nonspecific. We see that in chronic pancreatitis, but it's not uncommon for us also to find it next to tumor. Let me know if you guys have any additional questions that you want me to answer. There's a little bit more fibrosis.
I think we're good, yeah.
Okay.
I think it's an excellent demonstration. I think we're set. Sachin, do you have any parting remarks?
No, I just wanted to make one philosophical comment. Can I?
Yeah, of course.
Yeah, no, I just wanted to say what an honor and privilege it is to work here and with the fantastic nurses that we have in our lab. I only wish that I had taken a video or a picture just before I started this case. You should have seen all the nurses huddling up together and talking about how they're going to prepare for these next few hours here in our lab for the hands-on training and for RMIE, etc. So just wanted to say it's real honor and privilege to work with these nurses here. Thank you.
All right, thank you.
Good job.
All right, welcome back, everybody. We have one more presentation before we break for lunch. This one we're really excited about. We have two of our interventional nurses. They're going to give a presentation about their roles in interventional endoscopy. They're going to go through a few procedures, and you'll see, maybe some repeats of some info you learned earlier today. But this presentation is much more focused on the nursing aspect of everything. Think back to nursing school when you were doing your care plans and your nursing diagnosis. Same kind of thing. All righty. Here is Amy Larrabee and Chanel Carley.
Wow, looks very overwhelming up here, but I'm Amy Larrabee and this is Chanel. And we're here to present what we do every day as an interventional RN. I'm gonna come here. The role of us, really, it does play a vital role, as you guys have got to see on the live cases. We have to have closed loop communication and really focus on what we're doing together as a team in order for the procedures to go smoothly. There's always two RNs in one procedure. One RN circulates, but a lot of times if you have a complex case, you will both be teching. It's very rare for us to just sit there. We're very hands-on as a team. And then, as I said, sometimes one will get to tech and then one will actually get to just circulate.
And then for the circulating nurse, we get them from pre-op. A lot of times with therapeutics, it'll be both the teching and circulating nurse that make sure that we have all the consents. Very important to have anesthesia and the procedure consents signed before we bring them back to the room and get the patient sedated. We'll do a pre-induction timeout with the anesthesia provider, document the arrival time, staff, safety measures, do a little check-in with anesthesia, date of birth, name, MRN, just before everything gets started. And then once the doctor comes in, we'll do the big timeout. And then that's when we find out if we need any antibiotics, indomethacin, any concerns.
So I am going to follow up on our ERCP procedures, which I'm really thankful that you guys were able to see live cases and how that actually functioned. It was a pretty straightforward ERCP and you got to see the stone removal. And just to kind of loop you in on something that I thought was really heartfelt from my point of view, I attended RMIE, the previous RMIE, and I had no idea that this team existed. So whenever I attended it, then I was like, can I actually shadow here? Because I was like fascinated with the procedures that everybody was doing. And where I came from, we only did maybe one or two, and our nurses circulated, but no teching was involved. So just to kind of bring like a full circle picture, I was captured at RMIE, and then I shadowed here, fell in love with the procedures that we do, was offered to be a part of our really wonderful team. Still learning. I've only been here a year, so there's tons to learn. But these are really, really fascinating and remarkable procedures. And the things that they actually do for our patients, the outcomes, it's a big honor for me to be a part of the team, because I think all of us as nurses here, our number one is our patient, and that's my favorite thing to be a part of. I hear it all the time, like, come on, Amy, stop talking to the patient. You're talking too much, because I'll delay your process. But it's really fun to watch a patient tell you how awful they feel. And then when you do the procedure, you're a part of it. And then you go back, and I'm guilty. I will loop back in PACU, see the patient, and I'm like, wow, you feel a lot better. They may come back for a repeat, but it's like very fascinating, and just it's an honor to see how we help so many people with such like a different diverse population. They travel all over the world. So as a nurse, I really do focus on, hey, where'd you come from? Because the patients are probably as nervous as I am right now, because they travel from all over the world. Alaska, I mean, Montana, we get a ton. So I just kind of wanted to give you that backstory, because I'm really proud to be here, and I'm thankful that you guys wanted me here today to present. So thank you. So back into our ERCP that you guys got to see, I'm just going to go into the indications. The patient could have obstructive jaundice, biliary or pancreatic ductal system disease, like you guys have already been able to witness this morning. And so we do have treatment or tissue sampling or brushing for any type of suspicion for pancreatic cancer, pancreatitis of the unknown cause. I think a lot of times as nurses, we hear, oh, you have pancreatitis, we immediately go to alcohol. That's not the case all the time. So if you hear that, be mindful of that with your patients. And then biliary stenting for strictures or leakage. This is just a good setup to show you the scopes that we pull and how we kind of bring everything together in our rooms on the daily basis for our procedures. The scopes we use for ERCPs is the TJF. You're going to have different docs that you work with, and sometimes they'll be like, hey, Amy, go get me the duodenal scope. And I'm like, okay. And it's really the TJF, or, some will call it a side viewer. So it's really learning your physician's lingo and what they expect from you. We also have the JF 140, which is a smaller scope and a smaller working channel, and then the PCF and the SIF. I don't think any nurses in here want to hear, go get the SIF, because then you're like, well, hands on deck, we're in here for a long time. And that's for altered anatomy. And then the wire locking device, which I know there's going to be some in pictures that you can see. And then the tools that you guys got to witness earlier is, and these tools, once we get them for the procedures, we've already had a pretty in-depth conversation with the physicians from a previous procedure. Like, what would you like? This is what we did last time. And you just have extra, but your circulating backup partner, they'll go out and grab that as well. Native papillas, typically we get a wire and a tome, which you guys saw my other colleague, Amy, utilizing. And then a 20 millimeter snare for removal of plastic stents or a rat tooth if you're having a metal stent, and then contrast and lead. Lead meaning what we wear to protect ourselves from the fluoroscopy that we use. This is just a nice picture of really the behind the scenes of what we do. This is a setup for an ERCP. You can see the rapid refill, the tome, the scope. In the picture, the locking device is the green area next to the working channel. And again, they have different ones. We also have, it looks like a spy scope up there in case we want to go even further up and be able to access smaller areas. And hopefully you guys got to see that out in the lobby. Troubleshooting devices. If things aren't traveling too smoothly in an ERCP, the first thing I was always told is a wet wire is a happy wire. So you'll see us just drenching a gauze in water, and then we just wet everything. Every single pass, we wet the wire. We always flush devices with saline prior to loading them, just to make sure everything is going to function properly. And then we also utilize dilation balloons multiple times. When I open a device, we have a kind of a system that we use where we actually fold our towel a certain way. So we can lift the towel up, put devices in, and then continuously go back. And your partner, our team, our partner is constantly standing right there waiting. Like I call them my little Vanna White on the cart, because I'm like, they're waiting, we're here. And then on your dilation balloons, once you have dilated a patient, whenever you bring the balloon out, we do apply negative pressure, because that'll allow for a smoother transition to go back into the working channel and back into the ducts. Sometimes when you deflate the device, it'll still have a little bit of enlargement to it. So doing that negative pressure actually will help a ton. Blurred image or a halo around the image when you're using this scope, it's usually, I mean, we stated here it's Olympus scopes only. I'm not for sure 100% about that, but we did state that. And then ensure that the removable cap, which was in the previous picture, is correctly placed. And if that isn't, and you still have that halo, we'll actually remove the scope, replace that cap, and then start again. Artifact on fluoro, we run our own independent fluoro here. So we always make sure, and anesthesia is great about helping, that we don't have EKG leads in the way, or an arm, or anything that can actually obstruct the image of the physician being able to see what he's actually trying to see. We try to make sure that's out of the way. In regards to hemostasis, anything for a potential cause of bleeding during our ERCPs, that could be sphincterotomies, dilations, or stone removal. You guys, again, did get to really see a straightforward case, and that was adequate where there wasn't any bleeding. But in case with the balloon that you did get to see in that previous case, we actually utilized that to tamponade off that bleeding. So you can actually, when you heard Dr. Shaw saying go to 9, go to 12, we can actually go up and maybe we'll overinflate and just hold it there to tamponade any areas that we're potentially concerned about. Same thing, we can use a covered metal stent to tamponade that area as well. Special considerations for an ERCP, we want to make sure that there's nothing, again, that is going to be obstructing the C-arm. And like I had mentioned, IV lines, EKG leads, or ECG leads. Sometimes it'll just be anything that we have up there. It could be the lead that we have on the table or on the C-arm. You want to make sure that if you are using fluoro, that you adequately know how to utilize your C-arm and your fluoro. We have a nice rep that'll come and train us, because your docs will expect you to have the fluoro set up and ready to go for your procedures. And then a lot of our patients, they're in pretty poor health. So, you know, we do ERCPs to intervene and to actually give them that quality of life or palliative care, just so they can actually spend time with their families instead of constantly having to come back and forth to the hospital setting. And as we discussed earlier about post-ERCP pancreatitis, we want to make sure that we use extra fluids, 2 to 3 liters. That's something that we consistently, and during our timeout, we go over that. So anesthesia is aware. Hey, this is the indications, this is what we're going to do, this is the plan. We need antibiotics. You're going to be doing 2 to 3 liters, and we actually make sure pre-op and post-op, amazing. They're amazing to follow up, and they make sure that the patients all follow those guidelines. And then rectal indomethacin, like we had discussed earlier, and I really didn't realize it was truly as expensive as they had mentioned. So now it made more sense for me to understand why they are so reserved. Like, yes, we need to use this, or no, we don't. So it's actually really mindful of our team to be that mindful for patients in regards to their cost when it comes to ERCPs. So I'm going to hand this over to Chanel.
All right, and I'm going to talk about endoscopic mucosal resection. We use that for nodule Barrett's esophagus, large polyps, gastric cancers that have not invaded the muscle, and esophageal cancer not invading the muscle, or submucosa, because then Amy will talk more about ESD with you. In our setup, we use GIF, PCF, CF. So that's a regular upper scope, PEDS, colonoscope. And then the 1T and 2T are therapeutic scopes with 1 and 2 additional channels just to help with suction and using multiple tools at once. And depending on where the area is we want to resect, that will decide what scope we want to use. Tools and devices that we use a bunch of different snares. We have cold and hot snares, injection needles. We got a couple different kinds of those, lifting agent, coag grasper, clips, suture, closing devices, specimen trap, formalin jar, grounding pad, cautery device, and a distal attachment cap. Some equipment that we need to troubleshoot is the Irby or cautery devices. It's good to make sure everything is plugged in. Half of the time, that can be the answer to solving your problems, turns out. And then also make sure the patient is properly grounded and it's on there well. You'll see that on the RMIE, you'll turn green when you know the pad is in place. And then if you're having trouble opening and controlling the devices, just hold the devices as straight as possible. Sometimes they are defective, so if you are having issues after that, take it out and test it before you keep going with it. Hemostasis for EMR. Of course, if you're resecting something, you're going to have an increased chance of bleeding. We like to use the coag grasper that is used for prophylactic treatment of the vessels or active bleeding. You can touch the coag grasper to the area, or more effectively, you can grab the vessel with the coag grasper and pull it back and cauterize it that way. We use clips as well. There's different kinds of clips. Everybody has their own preference on those as well. So a lot of times with EMR, you'll just grab all of them and let the doctor tell you which ones they want. And then we have hemospray and Puristat. I saw hemospray out there, so I don't know if anybody got a chance to take a look at that or has used it before, but it's pretty effective. We use Puristat a lot now as well, which is like a clear epoxy almost, so you can see the whole area that you are treating, which is really nice. We also use suturing, and we use the X-Tack or Apollo suturing for that. Some special considerations with EMR. As in any procedure, communication is key, but especially when using cautery, the closed loop communication we keep talking about is very important. You also want to be aware of risk of perforation, anticipate that. You want to have things in the room to take care of that if it does happen. You want to turn the CO2 to ultra low or low based on what the doctor would like, but you would also want to anticipate obtaining an additional scope if needed, and then they could be admitted or have an extended recovery. And it's important to remain calm and focused. Don't freak out.
So we're going to discuss ESD and poems. And do any of you in here actually, are you a part of poems or ESDs? I know some people are out of state, so no one? My front row, not saying hi. So we'll go a little bit into this. These are really, they're really cool procedures. You're going to hear me say that about every procedure here, okay? I think this is like the greatest thing. So indications for ESD is to treatment of tumors or lesions that involve the submucosa, Barrett's esophagus, and the early stages of cancerous tumors or polyps. Personally, some of these I've been a part of, the pictures that you're seeing, and I just think it's really, I mean, that's a really cool quality of life to be able to remove that versus someone not being able to eat or have a feeding tube or things that move forward like that. I mean, this is really amazing. Setup for an ESD, we're going to use an upper scope or a PCF, could use a colon or a 1T or a 2T, depending on the devices that you're going to use. You're going to need an injection needle, also solution, and then that solution is usually typically like head-of-starch, methylene blue, and epi. Those are all dependent on your provider's preference. That's how we mix those solutions. Tools and devices, a lot of the tools are cutting tools, as previously discussed with the physician. We just don't randomly go get things. They know what they know what they are expecting because they've reviewed everything with the patient. And previously in some of these setups, they know exactly how far in depth they need to go. So again, we do discuss this with a physician. And then many of the tools have the ability to cut and inject, which is great because that is minimizing the time of us having to switch tools mid-procedure to inject, lift, and then go back in and cut that area that's needing to come out. Distal attachment cap, coag graspers, everybody's best friend in here. Clips, cautery devices, pump for injection, suturing devices, and hemospray or Puristat. This is a typical setup for an ESD, which is, it has everything on here like the injection needle and the devices, the pump, methylene blue. This is our typical setup where we just have everything on hand in case we do have anything happen. We just have everything where we can grab and go. And then hemostasis for ESD is similar to EMR. You have the coag graspers, prophylactic treatment of vessels, hemostasis of active bleeding, and then ensure to change the cautery settings when in use. That's one big thing. And I think our team does a really good job. We actually call that out to make sure the physician knows exactly what cautery setting he's on, and then he or she can let us know if they want that changed. Clips and suturing, and then closure of the resection site. Hemospray and Purestat can be used as prophylaxis or to stop the active bleeding. Indications for a poem. We have EPOEM, which primarily treats type 1 and type 2 achalasia, which is smooth muscle motility disorder. And Z-poem is a Zinker's diverticulum, which is a pouch that develops in the back of the throat. And then a G-poem is gastroparesis. So the sphincter is usually tight, preventing stomach contents from emptying into the small intestine. This is really, I got to see like from start to finish a patient that came in with the concerns and then moved forward with being diagnosed with, hey, you are going to move forward with an E-poem or a Z-poem, and then have a follow-up afterwards and to see like the quality of life and just the patient's overall outcome to say like, hey, can you make sure you thank this person when you wake up because I finally got my life back. I mean, I really like being a part of these as well. Set up for a poem. Scope, you're going to use upper scope, injection needle, the solution, typically just normal saline and meth blue. We want to see where we're going. And then tools and devices, again, it's physician dependent. Most cutting tools have the ability to inject, again, as we discussed. Distal attachment cap, coag graspers, clips, cautery devices, again, pump for injections and suturing devices. And then hemostasis for a poem, you're going to have coag graspers, prophylactic treatment of the vessels, hemostasis of active bleeding, and then ensure to change those cautery settings definitely in this procedure. Clips and suturing to close that resection site. Troubleshooting in both of procedures for the ESD or poem, really you just need to make sure that you're cleaning those devices, that they're plugged in properly, and just making sure and most of the time our partners, we literally will clean in between and just make sure everything's set properly. Special considerations for an ESD or poem during these procedures, we often are in the submucosal space, and that's a huge risk for perforation. So flagging the devices is super important. The one great thing about these devices, they all come with pre-made stickers and they will actually identify the tool you're using. So utilizing those is a huge benefit. These caissons are often requiring multiple tools, and it can be helpful for physicians to place tags near the end of the devices so they can quickly move devices in and out of the working channel. Meaning whenever we're in a procedure and your physician is going in and then bringing the device back out, we don't have to worry about, okay, how far are we going to go, or how far can you come out, because he or she already has a flag on that device where we know exactly what space we're in, because we're making sure we're not going too deep or not too shallow or off where we're the target area. Ultra low CO2 is utilized to prevent any type of crepitus, and that is where our circulator will actually feel on your patient's chest to make sure nothing's setting in. Every 15 minutes, I mean, pretty much every 5 minutes with us, we'll just be constantly double checking the belly, the chest, very hands-on during these procedures. These procedures are usually longer. Physicians may ask the circulating nurse to annotate certain stop times, like whenever we have an incision time or when's the myotomy start or anything like that. We are very detailed as to when the procedure is going to start, when we started, stopped, everything, just to make sure we're keeping that patient safe. And then for the post-op care for the poem only, the patient is admitted. We communicate with PACU, strict NPO, definitely no NG or OGs, and then they stay, and then post-op day 1, they have an esophagram to make sure they don't have any leaks and that they are ready to move forward to being discharged. And it looks like in here, on the flagging of devices, if you don't have any flags on your devices, we just use four pieces of tape, certain tape that we have to flag all the devices for ourselves. Now back to Chanel.
All right. Some more ultrasound. So that's nice. We got to see some live demonstrations and clips from different ultrasounds. So we have a little background on that, which is pretty cool. We do these ultrasounds to confirm or rule out suspected disease, diagnose cancers, detect biliary duct stones, drain pancreatic pseudocysts. We do the celiac plexus blocks or neurolysis. Those ones were the ones for pain. And then FNA and FNB to biopsy or drain from cysts or tumors. And then our setup, we have the two scopes, which we talked about earlier, the radial and the linear. Radial we use for staging, esophageal and gastric masses mostly, and then you can't do anything as far as FNA or FNB because there's no channel to put devices through for the radial. Then there's the linear, which that one is assessing the pancreas, bile duct, ampulla, and then you can do FNA, FNB for that, through that, and same with the celiac plexus block neurolysis, any of the therapeutic interventions you'd want to do with ultrasound. Sometimes you do use the radial first to stage, and then you'll use a CLA after to do whatever else you need while you're in there. So it's not uncommon to use both of those scopes during one procedure. There's a balloon at the distal end of the scope that you need to put on. They're different for the CLA and the radial. Sometimes they can be difficult to get on, so it's really important that you check to make sure that there's no water leaking out or any holes. And then you need to have the ultrasound processor, FNA, FNB needles, whatever the doctor requests, or we have some in the room that you can grab on the fly, and saline syringes and 10 ml syringes. All right, that is the setup, and then it's kind of hard to see, but that's where the balloon goes. So we have devices to help put it on. Yeah, it can be difficult sometimes if you've ever put them on, and very important to check the balloon is working before you get the case started and you're down in the area you need to and realize it's not working. And then in the background, you can see the towels and syringes. That's what we watched on that live case where they were getting the slides ready and preparation. Troubleshooting for the EUS. Sometimes the image is not showing on the screen. Again, make sure everything's plugged in. Check stores is on the correct setting. And then if the pedal is not working, just make sure there's no kinks in the cord and that the pedal is also plugged in. If you can't tell, we have had issues with things being plugged in before. Trouble with insufflation or balloon, like I said earlier, that can happen pretty frequently and very important just to check before you get started. Some special considerations for EUS. If your patient has a latex allergy, the balloons that we use are latex balloons. We have latex free, but it's very important before you set up and get everything going that your patient doesn't have a latex allergy so you can plan accordingly for them. Patients tend to be nervous about the information that the procedure will reveal a lot of times, so it's important to take extra time to comfort them if needed. Try to make them feel at ease if you can. It's kind of scary going into a procedure, finding out if you have cancer or not. So it's a thing to keep in mind. Risk of perforation is higher in the duodenum due to the size of the scope. And then, again, check the functionality of the balloon prior to the procedure. Hemostasis in EUS, the risk is a lot lower than with the RCP or EMR and ESD, but it can happen with the FNA and FNB. You're sampling with a needle. If they're on blood thinners, that can be higher risk, of course, as with any procedure. And then if you put an Axios in, that can also be a higher risk. That was I think we have a picture of the Axios. Oh, no. Anyways, the Axios was that metal stent that you deploy, and then it can make the connections between the stomach and the small intestine, or to drain pancreatic, or do necrosectomies. Okay.
So now we're going to discuss the small bowel enteroscopy. These pictures are, well, you can see those. So you know that this procedure is going to take quite some time, and with the circulating nurse, we're all working together during this one. Everyone's taking in this procedure. Indications, it's usually because there's a suspected small intestinal bleed, or this patient's had recurrent gastric bleeding, visible bleeding, or an iron deficiency anemia. A lot of times they've had capsules and they may capture something, they may not. So they're still having this recurrent issue. And now we're going to go in with the small bowel to see if we can find anything. And they've also had failed upper or lower endoscopies. The setup for this one is the single balloon. Double balloon is the Fuji, and then you have the single balloon, which is the SIF, and then we can also use the PCF. For the single balloon, it's the SIF Q180, and we have an overtube, insufflator, the distal attachment cap, and then you want to make sure that whenever you're preparing for this procedure, you have the correct devices that will actually travel down this single balloon because it's extremely long. For the double balloon, same thing. It's the scope is a Fuji, and then we also have the Fuji processor, an overtube, and a distal balloon. This one has the ability for two balloons to inflate. You have tubing, insufflator, water for both CO2 and irrigation, and then the distal cap and the correct, again, lengthened devices to utilize during that procedure. This is our setup. We have a really structured setup. We have the small bowel cart that has all of the devices already ready, so we don't have to run in and out of the room for the procedure. Our circulating nurse is right there. They can grab whatever we need. You definitely want extra padding on the floor because no matter what we do, when we use the overtube on this device, which you can kind of see in that picture, it's that plastic shiny area, it leaks water the entire time. So we just have water everywhere during that procedure. Troubleshooting for that, it could be a poor insufflation. Double check that biopsy port cap is properly placed, replace the biopsy port, or you can also get a stiffener if you need to utilize during that. That just makes everything the ability to move further down, stiffen the scope up for us so it'll travel down further. If you have trouble threading scope through the overtube, you definitely want to flush everything with water. I think we just say that for everything, but definitely this device. And then balloons not inflating, you want to check the tube connections and then check your balloons. We always check the balloons prior to starting before the patient even comes back. We check everything before we bring our patients back to make sure that everything's ready to go. Hemostasis for this, we use the APC. All standard probes are long enough to go into the SIF and the Fuji scopes. They're specialized thinner probe that is ideal for the small bowel scope, and it's easier to suction the argon gas while it's down the working channel, and then clips if you find anything. Special considerations, oftentimes in altered anatomy, the circulating RN will also assist in teching. And then it's helpful to always have that extra lubrication because as we're advancing that overtube, sometimes it'll get stuck, it'll feel stiff. So the more lube that you actually lubricate that device with, the easier it'll travel down for the patient. And then definitely keep extra PPE because of the water usage. Fuji balloon and the overtube are made of latex, so that's definitely a double checking area for a patient's allergies. And then use proper body mechanics because this can be quite long and you're standing in one position and your arms feel like it's a pretty tough workout. So yeah. I think there's an alternative single balloon. Yeah, just the single balloon.
The question, sorry, we have a microphone for questions, so just flag us down. The question, in case y'all didn't hear, was what do we do if a patient needs a double balloon and they have a latex allergy? At this current point in time, they cannot get one, is what they had said.
Right. Or if the physician decides to do single balloon. So, yeah. Any questions, you guys? Thanks for coming today. Oh, sure. I'm like, where's the chat? I don't see the chat. I mean, I'll literally be like,
So forgive any mispronunciations. I'm not clinical. So the question from Jennifer is, where do you obtain pinning material for N-block ESD specimens? And do you always pin these for path? Do you use EndoFlip with your POEMs? Which ones?
Okay, so for the first part, for the pinning, we actually have our cart set up. Everything's readily available for the physician. And they will tell us like how much boarding they need, how many pins, and then they pin everything for those. And then the second part was the clips. Can you repeat the second part, please? Oh, the EndoFlip.
The second part was, do you use EndoFlip with your POEMs? And if so, which ones?
So prior to a patient moving forward with a poem, which I mentioned earlier in regards to the G poem or the E poem, they do have endo flips to make sure that they are a candidate to be able to move forward with the poem procedure. And I'm not certain on the actual endo flip that we use, if someone in here wants to. Yeah. I just didn't know if it was like a certain name that they were looking for, but we do utilize the endo flip, which is where you actually get to see, you get to see the hardships of your patients before they actually move forward with the poem. And then when they come back, you get to see the quality of life that that poem has provided to the patient. So yes, we do endo flip prior to poems.
Speaking of poems, just because we don't really have a lot more in-depth discussion about poem and ESD, do you mind going back to that first slide and just kind of explaining what exactly we're doing in poems and ESDs, like what the procedure does? Because we know it's for achalasia, but how do we fix the achalasia?
Sure, let me go back. Sorry, guys, this is super, super slow. This is as slow as we move during the poem, just to let you know. So. To this slide. Let's see. Is this the slide you were talking about? We're getting there, guys. Promise. Oh, there it is.
There we go.
You want to come chat to this, Lila? I knew you were going to.
Okay, so I just kind of wanted to go over this a little bit, just so you all have like a little bit of a better understanding of what we're doing. We call these like third spacing procedures because we're in that submucosa. Again, that's at higher risk for perforation, bleeding, those sorts of things, because we have all those vessels in there. So with an ESD, it's cool. It's different from an EMR in the fact that we are kind of tunneling under a lesion and going around it and moving it all off in one piece. So then you can see we have like that entire lesion coming out. And as Amy kind of touched on earlier, we are able to avoid hemicolectomies and esophagectomies when we do these procedures. So the quality of life for patients is definitely improved. And then with our poems, what we do with those is we make an incision. This is a example of an esophageal poem. So you make an incision inside the esophagus, and then we actually tunnel through the submucosa, as you can see with the scope here. So we make a tunnel, and then we also take a knife and then cut all of the circular muscle. So it relaxes that muscle, and hopefully the end goal is to help with swallowing. Same kind of idea with the G poem, we're doing the same thing to the pylorus. So we're relaxing that sphincter so food can pass through. Do we have any other questions? Coming right over to you, Lila.
For the small bowel enteroscopies, what would be the indication of single balloon versus double balloon? What would be a deciding factor between doing one or the other?
That's a great question. A lot of it is physician preference. Usually we're going to go for a single balloon or a PCF, like the easier thing we're going to try first. So if it's an altered anatomy, but we think we can get there with a PCF, as I'm speaking in terms of like an ERCP, or an SIF, usually we'll go that route. If they've had like a failed SIF that we're trying to do an ERCP, or we're trying to look for a source of bleeding in the small bowel, then we'll kind of increase to the double balloon. But typically we try to use the single balloon if we can. It's physician preference as well. Anyone else? Anybody else? We did have another question that was asked about a previous presentation, but I left it over there. So I'm going to answer that because it was in the chat. Okay, so the question earlier in the chat was from Jennifer, and she asked if there's anything that nurses and techs can do to make our slides more optimal when we're sampling. We did get to kind of watch Christy. She was checking that last procedure during the ultrasound. We kind of got to watch what she was doing. That slow pull that Dr. Obach also talked about today, that is definitely going to help get a better sample. Kind of think of like when you were a kid and you were messing around in a restaurant with like your straw and you like put your finger on it and pull things up, same kind of idea. So doing the slow pull, communicating with the physician, I don't know if you all were able to see, she did put like a little suction syringe on after the instruction of the physician. Another thing that is very important when we do that as techs is us looking at that syringe and making sure we don't see a bunch of blood or anything weird or crazy coming up into that syringe, because that could mean that the needle moved into a vessel or something, especially in that case that there were so many tiny vessels around the lesion. And then as far as making the slides, the cytology tech is the one that makes the slides. However, we're handling one side of the needle and the stylet. So it's all about communication. And then, just making sure that you advance the stylet as much as the cytotech wants you to. Sometimes they'll make you go all the way. Sometimes they want you to flush air. And so that's the best way to optimize your slides. We've got one more question back there.
Hi, why do you have two RNs in the room versus an RN and an endotech?
That's a great question. In our general GI side, we do use endotechs, and we are very thankful for them. At this facility, our teching side of things for interventional procedures, our nurses do quite a bit. So it's very important to kind of have that education and background of what's going on disease process wise, what's going on anatomy wise, especially if your tech is handling a wire and you're in someone's pancreas. There's just an increased risk of, adverse events. So we want to make sure that we have like the time and the training to help with
We also
that. Yeah.
switch roles every case or every other case. So it's not like one person is circulating all day or standing up, teching all day. It's nice to be able to flip flop. So, you're switching the roles every other case. So another reason. Nice.
Yes. Anyone else?
Thank you.
Okay, so we're going to adjourn until the afternoon. We are a little bit early, so please enjoy lunch. I think we're returning. 1. Please be back in here at 1. We have a couple more lectures in the afternoon. In the meantime, please come up to us with any questions or anything. And I know a few of you have asked me questions about slides and things. I will follow up on that for you.